Bore da chi gyd, a croeso I Bwrdd Iechyd Prifysgol Aneurin. Welcome to the Health Board and our meeting today. Could I welcome those guests who have just arrived for the patient story? Thank you so much for coming in this morning. I'd also like to welcome Polly Fraser and Toko, who are our aspiring board members, and we're very pleased to see you here this morning. Today's meeting will also be available for viewing via the Health Board's YouTube channel following the conclusion of this meeting. We have a number of apologies. James Calvert, Andy is here instead, welcome. Peter Carr and Colette is representing him. Morning. Sarah Simmons and Shelley is representing her, and Leanne Watkins, and she's irreplaceable. So nobody is representing her. Now, are there any declarations of interest that need to be noted before we start this meeting, please? No, thank you. If we move to 2, the consent agenda business. If are there any items anybody would wish to bring forward from the consent agenda to the main agenda for discussion today? No, thank you. Update from the chair, and I've forgotten my notes, so I'm going to have to make this up. Right. It's been very busy, and actually some of it's been really nice because I've done a lot of visits recently to see some of the schemes that we have funded over the past 4 years, and I've asked those who presented to me about what actually happened to come to our board briefing meetings so that we can all have the benefit of that, particularly the things like the fracture liaison service, which have really blossomed, that seem to be at the moment unequally distributed throughout Gwent. So I've asked them for an update on that so that they can inform the board, because there seems to be no reason really why we should be having any inequality of access. The chairs have met. Difficult times, I think, were appreciated by all the health boards particularly, and we did discuss how we work more constructively together, and we are working with the chief executives in trying to define what a primary care service that is sustainable might look like in the future, and that work is ongoing. We have also, I've been very fortunate with my visits in being asked to open something. I never get asked to be opening anything, but I did, to the visitors room in Yav, which is lovely and funded by the League of Friends, which was jolly good, and it really has made such a difference to particularly the palliative care patients' relatives up there. And there was a lovely exposition from one of the patient's relatives who found that the visitors room and the ambience that had been created to be really sustaining for them in very, very difficult times. So that was good, and I would urge you to all go and have a look at it and listen to what the staff and the relatives have to say about that service. We have had a number of meetings about the new care system to replace the Care Action Committee. We're still a little concerned about the actual way in which it could work and how it will be accountable and what it expects to achieve, which we have placed in front of Welsh Government officials. We haven't had any responses yet. But in the meantime, the rest of the business has been hugely busy and very grueling. But as Nicola will report, we have had some success in being downgraded in terms of escalation. So well done to the teams to manage that, and Nicola will explain that in greater detail, particularly when we noticed that some of our colleagues in the South East have actually gone in the other direction, which is very difficult for them to manage. So that has been good. and we are sticking rigidly to the plan that we have agreed to ensure that we maintain services and don't overspend. And we'll be coming back to that during the meeting. So it's been a very, very busy time, but there have been some real lovely highlights in terms of actually seeing exactly what the staff are managing to do on the ground and how creative and innovative they remain in the face of quite inexorable pressures. So I've been uplifted, I think, a bit to have seen that. So that's what I've been up to that I can remember. Nicola?
Yeah, thanks, Chair. So quite a number
She's
of
looking
things.
at her, she's written it all down.
Yes, I've got listed. It's been a busy couple of months. We've kind of spent quite a lot of time over the last 2 months doing our annual divisional reviews and the corporate departments to kind of really focus on the achievements over the last 12 months, some of those key challenges, and then how they are forming the priorities for each of the divisions. And it is a really good, helpful process where you kind of pull all of those together. I think it's really helpful for the divisions and corporate teams as well to kind of pause, have a look back at what they have delivered, but then what's been challenging and what we focus on going forward. And that included our joint executive team meeting with Welsh Government, which we have twice a year, which was a kind of very constructive meeting and quite despite recognition of some of our challenges, but also recognition of some of the areas of progress. So overall, we felt it was a really positive meeting. And on the back of that, we were informed that we had an approved INTP recently by Welsh Government, which is really positive because we haven't had one for a number of years. And you will have also seen yesterday there was an update on all of the escalation status of health boards, and we were de-escalated from level 4 for planning and finance down to level 3 enhanced monitoring. So we are still in escalation, which I think is appropriate because I think we all know that we have got a significant challenge to deliver this year's plan, and we've come far from sitting on laurels on that one. But I think what it is in recognition of is the significant work we've done on our planning. There's quite a lot of recognition from Welsh Government on the focus we've made on the strategy, the focus in there around population health and the work we're trying to do around place-based care, alongside delivery and progress around some of the key ministerial authorities and general performance. So like I said, we've got lots of work to do, but I think good to see some of our recognition coming through. We've remained in level 3, which is enhanced monitoring for urgent emergency care. Pathways at the Grange, which I think we're not surprised at. Whilst we're making some improvement, we've not hit our de-escalation criteria, and we've got plans in place to get there at the end of this year. And we've tried to put a real kind of refresh focus in the last 2 weeks on particularly those delays in ED and the ambulance handover times, and the work that's been done nationally around 45-minute handover, looking at that becoming a national mandate later in this year and how we need to make sure we prepare for that. So a huge amount of focus still going on around that. We are slightly worried about an ED extension programme, which is kind of facing delays, which we are picking up with the contractors to look at how we make sure we mitigate any risk of that drifting into the winter, and I can give the board a more detailed on that separately. The other piece of work I just want to raise, there's huge amounts of work going on around the National Outpatient Programme. This is Welsh Government's commitment to try to reduce the waiting list by 200,000 by the end of next year, with a big focus on outpatients. This is huge amounts of work with help, but it's really welcome to have additional funding to support this. But we are talking about delivering in excess of 1,000 outpatients every week for the remainder of the year till March. So we're currently working through that because the plan is this starts being implemented around August. So we are currently working, but as you can imagine, it's going to be a huge endeavour to deliver that. So not without risk. So we are working as hard as we can to make sure we pick up operational risks and issues so we can work those through and deliver the best we can for our population. There's continued dialogue alongside that around our 104-week position, which again is a commitment. We want to get that to 0, at least hold last year's position. And we've currently got risks around that in terms of trying to secure additional funding for ages 2 to 4. You'll pick up some of that in the performance report. In terms of, it's worth noting, James isn't here, and he's here to represent him, but we did go through a comprehensive recruitment process for the medical director, and I'm pleased to announce that we appointed Seema Shivastara, I think is how you pronounce the surname, who will be joining us around October time, but we're still waiting for their dates. And obviously there was a panel and Bill and we're alongside the CMO. So there'll be more to follow on that in September. And then just to finalise, as Anne said, we've been out and about in different places, and I've been involved in some great events over the last few months, and lots of it with a kind of equality, diversity, inclusion kind of theme to it, which has been really important given our commitment to this. So there's been huge amounts of activities going on around Pride Month, and I was pleased to attend the Cardiff Pride event, which was really celebratory and uplifting. I also got invited to the Filipino Independence Day, where they were celebrating the cultural diversity with all of our Filipino nurses, who've really brought some great joy as well as experience to our health board. And the nursing conference recently as a theme that was about equality, diversity and inclusion, again, was a hugely successful, uplifting event, and really proud to be part of that. I know Helen, you was there, and it was great to be part of. And then those of you who were at the Staff Recognition Awards on the 4th of July, a huge event, over 500 staff there, and was such a great positive night celebrating the amazing achievements of so many of our staff, which is really great to see, and you really get some great feedback. And as we mentioned on the night, it's just a snippet of some of the great work across the health board, and was there to celebrate the 15,000 staff that we have in the health board. And I think just picking up, we got on the agenda later, but I'm really pleased with the work we've done as well on the values framework and refreshing our values to something much simpler, which is about kind of our ethos around kindness, integrity and respect, which we're going to try and hopefully sign off and really try to drive that through the organisation with those simple messages. So I'm going to pause on that point, but hopefully, it's been a busy couple of months, but with some real positive news in there as well. Thank you.
Thank you. Any questions for Nicola? No? Okay. On we go. 4 and 4.1, the patient experience presentation, and I'm really pleased to welcome Nimit Goyal, the consultant radiologist, here today with his patient. If you'd like to introduce yourself.
My name is Leighton Powell. I'm a MSK physiotherapist. I've been studying in Devon. So I'm here with 2 hats on. I'm here as a physiotherapist, but I'm also here as a patient.
Thank you. Thank you very much for coming
today.
Yeah, thank you very much for inviting us to present this story on this really innovative option we have come up with for knee osteoarthritis patients. So can we move to the next slide, please? So why talk about osteoarthritis? I think the main reason is because it's so widely prevalent, and about 1/3 of adults in UK above the age of 45 suffer from osteoarthritis. So that means in our health board alone, there are more than 80,000 patients suffering from osteoarthritis. And while prevalence is important, but a disease that is this prevalent obviously comes with cost as well. So move on to the next slide, please. So these are just some figures. So NHS spends more than £10 billion annually to treat arthritis, and it's projected to go up to 120 billion almost, which is about 12 billion in the next decade. And that's the cost for NHS. And there is also an indirect cost of about 2.5 billion for the working days lost because of osteoarthritis. Move on, please. So while that is the cost aspect, there is a patient in the middle of it all. And we'll meet the real Paul Gibbs, but this is representing Paul. And if you keep scrolling very slowly, so Paul developed osteoarthritis and he went to his GP. And he said, oh, I've got pain in my knee. GP got an X-ray done for him, gave him some painkillers. Didn't work, gave him a steroid injection, didn't work. So sent him to Leighton. And Leighton did physiotherapy, which worked for a bit. But because Paul was in so much pain, he was unable to comply with it. So Leighton gave him another injection after an X-ray. Move forward, please. Yeah. His osteoarthritis has deteriorated slightly. He got a second injection, which worked even shorter duration than the first injection. So there was a bit of to and fro between the GP and physiotherapy department. And then ultimately they decided that let's move up a step. So they sent him to orthopedic surgeons. Now, orthopedic surgeons at this stage, because this is Paul's X-ray, this is not quite ready for a knee replacement. Move forward, please. So they gave him another steroid injection. He had a PRP injection, which our health board offers, but all of them were very short acting and didn't really help. He got an MRI scan done, which confirmed there is osteoarthritis, but because his X-ray didn't quite look like, next slide, this, which is what is an X-ray, a knee which is ready for a knee replacement. So he's not quite a candidate for knee replacement. And also patients who do have knee replacement, unfortunately, can up to 25% of patients carry on having knee pain even after knee replacement. So essentially, Paul is stuck. Yeah, keep going forward, please. In this cycle between seeing his GP, his physiotherapist, and his orthopedic surgeon, and still in pain. So before we started doing this procedure, we asked ourselves 3 questions. So if you go forward, can we reduce the need for painkillers for Paul? And while he's working with his physiotherapist, can we make patients pain-free so that they can work better with physiotherapy? And the third question we asked that, can we delay the need for total knee replacement and keep patients pain-free until then? So on the next slide is actually Paul's video, so I'll share that with you.
I got osteoarthritis. I got a job to walk. It gives out. So yeah, it impacts my life, just constantly living on painkillers.
MSK or musculoskeletal problems are basically all of us above a certain age tend to find aches and pains in the body. Traditionally, they have been treated by physiotherapists and orthopedic surgeons who are still very much at the center of this treatment.
There's about 12% of the population that have got some form of osteoarthritis. We just can't keep up. We can't operate our way out of this problem.
Many patients are living with moderate or above pain levels because of their osteoarthritis. They've already tried conservative treatment options such as physical therapy, physiotherapy, pain medication, anti-inflammatory medications, and a variety of knee injections such as steroid injections.
We still left with a significant number of patients that have got quite disabling pain at a young age, but essentially you can't help and they're not ready for a total knee replacement.
There is now increasing evidence that intervention radiology can provide an alternative for long-term pain relief for these patients. Intervention radiology, as the name suggests, is using radiology to intervene on people to treat various diseases. So what we essentially do is we use image such as ultrasound, CT scans, fluoroscopy screens you can see behind us to guide a variety of treatments in patients.
Genicular artery embolization is a procedure which essentially fills a current gap in the treatment options for patients suffering with osteoarthritis of the knee.
You know, it's far less invasive than a knee replacement. It's slightly more invasive than an injection, but it lasts a long time.
And because what we are offering is minimally invasive, we are potentially able to treat patients who are not fit enough for conventional surgery.
Using a microcatheter will go in via the groin, make a very, very small hole. I always describe it to patients as like the size of a pen top. So I usually show them in clinic and say, the hole we're making is about this size, just to reassure them that it's not big open surgery. And then we inject particles to cut off the blood supply to that area.
So our patient today, as you know, is a young gentleman. He's only 54 years of age, and this knee osteoarthritis is stopping him from doing day-to-day activities. He's a carer, and he finds it difficult to deliver his job because of that as well. We expect him to leave this hospital in about 4 hours after the procedure. He'll be able to walk home.
Oh, game changer. Like I slammed the weight on, I can go back to the gym, I can do more exercising.
And that is what we really want to achieve here, is that for patients to go back to their routine life, to enjoy their routine life.
It's really lovely to hear the positive stories that are coming back from our participants. It has absolutely massive potential to really improve the lives of people living in pain and with reduced mobility.
They're all delighted by it. And it's a return to function with little or minimal symptoms. It has a large impact, and it's a lasting impact.
The pain relief can last for up to 2 years and potentially even longer. So what we can potentially achieve here for our patients is that we do a procedure and we make them pain-free for a prolonged period of time and potentially off the medications as well.
And that means these patients can go back to work, they can be productive members of society, and they're not in agony, which is exactly what we want to see.
NHS, as you know, is under pressure and the waiting lists are only getting bigger. By having intervention radiology deliver a procedure which conventionally has not been delivered by intervention radiology, we are hopefully taking pressure off our physiotherapy and orthopedic colleagues and just contributing to patients' care.
Potential impact of this treatment is huge. If it does show that it's a disease modifier, then we will in the future reduce the waiting list.
So the benefit is immense. You've got patients back into work. We are stopping their multiple visits to primary care center, to their GPs. We are stopping multiple visits to physiotherapists and orthopedic surgeons. In addition, we are breaking the habit of reliance on pain relief. I think this is one procedure that is going to change the face of intervention radiology. And that's just because of the prevalence of MSK conditions that we have and the potential to provide long-term pain relief.
I think this procedure has got huge potential to grow into other musculoskeletal conditions. And we're really excited to be able to lead some of the research contributing to that.
This is a very promising procedure which has got the potential to change patients' life.
But now, oh my God, I wish it was still available years ago. It feels stronger. It's amazing. Unbelievable. Because I was depressed, I gotta be honest. Living in constant pain. But now, my mood have changed. I'm doing more. I'm not stuck in a rut. Yeah, I can run up the stairs now, come down the stairs, okay, with confidence. Started playing football again with my grandkids. Yeah, it dramatically changed my life.
Thank you.
We move on to the next slide, please. So that was one patient story, and it is quite a moving story. And I mean, Paul is great and he's very, very happy. But we have done this procedure on more than 50 patients now, but we have included data for about 30 patients here. And our data has shown that it improves pain. Our baseline pain was around 70, and at 1 year, we are down to about 40 still. Next slide. And this is Oxford Knee Score is a scoring system for function of the knee, and the higher the score, the better it is. So it was down to around 20 when we started for average, and then it is up to about 30 at 1 year. So, and then next slide, please. And we have not seen any adverse event during our patients. So we have proven that this is a safe procedure which improves pain and improves function. Next slide, please. So I'm going to hand over to Leighton, and he's going to share his own perspective on it.
So the physiotherapy service has 5,000 referrals every year for mechanical knee pain. And the majority of that is for degenerative joint disease. Okay, so about 4 years ago, I was one of those 5,000. Next slide, please. Okay, so my colleague here, who was on the video, who's the clinical lead for lower limb in MSK, came to the department and explained the inclusion criteria. So I said, hey, that's me, both knees. I was quite keen to get on this. So the inclusion criteria is pain over 5 out of 10, constant pain over 5 out of 10. For me, I'm a walker. I live in Newbridge, so inevitably it's up and down a mountain. And when I come down the mountain, my pain would go up to 8 out of 10. I had an X-ray and it showed mild to moderate OA. So what did I try before I had the procedure? I tried all this physiotherapy nonsense. So I tried the exercise. Yeah, so we run a thing called OAK, which is an education session which anybody with arthritic knees can refer themselves into. So the idea of this is that it stands for options, advice and knowledge. So we give the patient as much knowledge as we can about arthritis. We give them some advice then on how they can manage it themselves. And at the end of it, they've got a certain amount of options they can choose, which include one-to-one physiotherapy, general exercise, or in this case, escape pain, which is a bespoke exercise program which is running in the community. So Fortunately, I was actually taking the class, the escape pain class myself, but I also went in as a patient twice, and I had 2 injections in my knee as well. So I had some benefit from it, but I still would have this 8 out of 10 pain when I was walking. So 2 years ago, I had the procedure. So how did it affect me? So the arthritis, was reducing my function, reducing my exercise tolerance. And when I went on for my walk, I would take pain relief. I felt I needed pain relief. Okay, so 2 years ago, I had the procedure. Next, please. So it increased my function. It was great. I could walk more. I know on a Friday, I have a group of friends and we walk 6.5 miles every Friday. I also walk on the weekends now, and every lunchtime, as long as the weather's all right, I do a 20-minute walk. Yeah, it increased my exercise tolerance. I also did more exercise. I took some of the stuff from the escape pain program, and I do every day, every morning before I go to work. And I don't take any pain relief whatsoever. I improved my well-being due to all the above. I feel much happier. Okay. And as I said initially, I reached the criteria for both knees. Now, I wouldn't meet the criteria to have this procedure.
Thank you, Leighton, for sharing here. So I won't take too much of your time. I just wanted to have a couple of slides about what else can we achieve with this. So osteoarthritis is one aspect of pain-causing musculoskeletal conditions, and large joint tendinopathies are another big area, which, as you can see in this diagram, can affect all parts of the body. Next slide, please. So I'm just going to focus on 3 main ones which affect the lower limbs. There is one affecting the hip called greater trochanteric pain syndrome, plantar fasciitis, and Achilles tendinopathy, which affects around the heel. So next slide. It's quite a prevalent disease. And again, if we just focus on the lowest numbers, in our health board alone, there are about 120,000 people living with this condition, one of these conditions. So it's extremely prevalent, and this prevalence again causes 2 issues. Next one. One is huge waiting lists, because these patients are at multiple stages in their pain pathway. So they are seeing their GPs, they are waiting to see their physiotherapists, some of them are waiting to see podiatrists, some are waiting to get shockwave therapy. So they are in the waiting list at multiple points. But even if we think about these patients who have exhausted all the options, those are called recalcitrant cases. So if you move on, please. So these recalcitrant cases, next slide, have actually reached the end of the current treatment options that we can offer them. So for these patients, there is absolutely no option other than having something that we can offer in the form of embolization. I'll end my presentation with that. Thank you very much.
Thank you very much, Dr. Gore. Thank you, Leighton, for your very explicit journey explanation. Are there any questions? Rob?
Yeah, thanks for that. Really interesting. I am aware of it, but it's good to hear the detail a bit more specifically from a patient as well as a staff member. I was interested in the Oxford knee score, and you identified 40 as the average that the results that are coming through. What would that score be for a fit person?
48.
48. So that's quite close in terms of scale. It is close then. Yeah. Okay. And in terms of the treatment, are these patients, I'm presuming they're not suitable for a hip replacement or a knee replacement due to the condition? It's management for a longer period than current care.
So, I mean, knee replacement, because that is what the knee was the project. The patients have to have quite severe osteoarthritis. So osteoarthritis, without going into too much technical detail, can be graded from 1 to 4. And generally, grade 4 is considered suitable for knee replacement.
Okay.
But there are a lot of patients with grade 2 and 3 osteoarthritis who are in severe pain. Yeah. So those were the patients we were targeting here. It's basically a pain relief option.
Yeah, and I see your scores was was over 12 months, what's the sort of life of the injection?
So we are going to follow our cohort of patients for 24 months. So we will know next year around February exactly how long they have lasted. But we know from other literature that definitely 2 and up to 5 years there is benefit in these patients.
So my experience,
Yes, of course.
18 months I was completely pain-free. So I got a little bit of pain back now, I would say, but I still don't get the 5 out of 10. 50 out of 100, whichever way it was. So for me, it's been a fantastic experience.
Brilliant. Thank you very much.
Thank you.
Yeah. It was more a comment really. I just wanted to thank Nimit and Leighton for coming. You know, again, it's a really great opportunity to share some of the quality improvement, the R&D work that we're doing to really improve patient outcomes and patient experience. And this will give people the opportunity to live more fulfilling lives and, you know, to ensure that they're living those, you know, in a state of positive health and well-being. So, you know, I think it's important that we share those developments and, you know, those quality improvements, because it does make a difference to outcomes and eventually our performance and the money as well. So I just wanted to thank you for sharing and later.
Thank you.
Thank you. Akmal?
Yeah, thank you very much. Yeah, I think it's very impressive, and especially the way you have presented it. I thought it was very, very much focused. 2 things which I wanted to just ask. One, is it possible to share this across Wales or nationally through any journal or article? Because I think it's very good, impressive work that you both of you.
Yeah. So,
secondly,
sorry.
Secondly, the 3 key areas like the GTPS and plantar fasciitis and all that, there's quite a lot of waiting list numbers. And I was just wondering, how can that be fit into a strategy? I know knee replacement is the higher end of it, but these other 3 conditions, there's quite a huge number that you've mentioned. So how can those be part of the system to be able to make it more effective and good patient quality life that we can give to our people?
So, I mean, to answer the first question, because the trial is still halfway, we are going to follow patients up for 2 years. So we have presented it in international conferences already, our 1-year data. So we are going to publish it at 2 years. But we were thinking once it has been presented to the board that we can maybe make this video available. It will go on the YouTube, but as a standalone video itself from Aneurin Bevan, and that will be out there in the public. And your second question, I think it's really important. And what I realized working with our physiotherapy colleagues, because our physiotherapy colleagues have got clinics everywhere in the health board. And as consultants, we are much more hospital-based. And by working closely with physiotherapy for plantar fasciitis, we'll be working very closely with podiatry colleagues as well. We are actually reaching out to everywhere in our health board. So, you know, earlier there was a mention that there needs to be a bit of equality of access. So I think because we are working at grassroots almost here, then we are providing patients access. So we are at a stage now that this procedure is there. It's being done in USA, it's being done in Japan quite freely, but not yet in UK. So, but we know it works. So we are at a stage that we can potentially offer it. But at the very least, what we need to do before that is do a little trial like we did for knee osteoarthritis to prove that it works in our patient cohort as well, and then establish it into current patient pathways.
Thank you.
Can I just take up the point of inequality? It always concerns me that we have these brilliant self-referral systems, but I'm not always convinced that people actually know about them or understand how to access them, and to what extent the general practitioners universally within our area know about this procedure and how to get people in it, rather than the constant referral to having an injection, here's your painkillers, and we'll see you in 6 months. You know, how do you have any trouble trying to get out the information? Because it's vital. There's no point in having self-referral clinics if people don't actually know how to do it or have the confidence to use it that
So-
they won't be rejected.
Absolutely. I mean, I became a radiologist thinking that I'll work in a nice, quiet, dark room and won't be disturbed by it.
Oh, hard
I
luck.
started doing this project and I realized I need to go out and talk to people. And I think that's where the answer lies, communication. And I had initially spoken to all our orthopedic colleagues about it. But when I actually spoke to Hugh first and then Leighton, who are our physiotherapists, that's when this project just sort of exploded. And suddenly there were so many patients wanting to have the procedure done. So I think it's identifying that where these patients are coming from. So as you mentioned, if GPs are the gatekeepers for a certain condition, then we need to reach out to GPs about that. This is what we are doing. So it will be all condition based. For osteoarthritis, I think it's quite important to have a trained professional, because I'm a radiologist. I put my hands up that I don't know how to examine knees properly. Leighton does. So that's why we're using physiotherapy and orthopedic colleagues as our gatekeepers for this. And once they tell us that this patient is fit for this procedure, that's when they refer them on to us.
Thank you.
Can I just say something about that? Well, I think access, well, we do this OAK thing, which can be referred, people self-refer, but the information is in the GP surgeries and everywhere, and there's very little take up on it. Like, in my opinion, everybody with arthritic knee should go through OAK because it gives the patient choice. Yeah, and then if we have this as one of the options as well. We haven't yet, obviously, because it's not widespread technique. But I think the OAK, because it gives our patients some control over where they want to go with their problem.
If you want to add to that, Andy.
It's one of a plethora of points I'm going to go at in a minute. I'm not going to interrupt Leighton at this point, but yeah.
So I think that's something we don't utilise that pathway properly yet.
No, I don't think people know about it. Colette, what can we do?
Apologies. I was just going to say well done, and I was going to ask a question around how repeatable is this intervention? So if the pain relief wears off within 2 to 5
I
years.
asked him it earlier on. Yeah, exact question.
Potentially was one thing. And secondly, I recognise what you're saying about Oak Leighton, and that's essential, but we also have other options for people waiting for this intervention or following it around Good Boost, which is sort of self-directed and water-based activities that can be prescribed. So it's how we could link to make that link between the two options available for all your patients.
I think we are ideal places, physiotherapists, to get that message over, to be honest.
Absolutely. And we're quite chopsy.
Yeah. Trying to be
But repeatability question, I think there haven't been many studies done around it, but the general consensus is that we aim to get at least 2 years worth of pain relief. So if someone gets that amount of pain relief and then starts to get pain again, then we can do it. But if say someone only gets 3 to 6 months worth of, then it's not cost effective.
Okay. Thank you.
Thank you. Paul?
Very impressive. Huge thanks for your presentations. Wonder about side effects? I mean, one thing the patients will be looking at will be, okay, I have this, what are the side effects? Because I think probably, because is it radiation? I mean, that's probably one of the things that people are worried about, anything to do with radiation. I mean, how do you sort of explain that to people?
Yeah.
So patient.
So because the data I presented was all done as part of the research. So there is the radiation assurance committee to which we have to present how much will be the expected radiation dose and everything. So that went out, and then they send a document back that this is what you have to put in the patient information sheet.
Right.
So we put all of that, and essentially for radiation, when it's dealing with chest and abdomen, the same sort of X-ray will have a lot more dose compared to say X-ray of the knee. And that's just that tissues are sensitive differently to different amounts of radiation. So a knee aspect of things, the radiation dose itself is actually quite minimal. So comparing it, it's actually compares to about having a CT scan of the abdomen done, this procedure, roughly. So which is not a huge amount of dose, but it is still a radiation dose. So patients are all informed that there is a radiation component to it.
And any side effects?
So side effect wise, I mean, pretty much 22 of our patients had a little bit of skin discoloration around the knee. And that's because the same arteries that supply the knee joint supply the overlying skin as well. But that was self-limiting, and in everyone it settled after about 4 weeks.
So you were made aware of the side effects before you agreed to the procedure. I didn't have any.
I mean, the exciting bit is looking at other locations. Is that the next? You mentioned, I think, Japan and America. Have they used them in other parts of the body?
Yes. So in Japan, there is a professor called Professor Okuno, who is sort of the main person doing MSK embolization, as we call it. And he's doing it for all types of joints and tendons and getting excellent results as well. So that is what we are looking to achieve in UK. And Aneurin Bevan, I mean, one thing I didn't mention was we were the second site in whole of the UK when we started doing these procedures, and still are only one of 3 in the whole of UK doing these procedures.
I think it's well done. Is there anything you need from the board that we can assist you with?
Thank you very much for asking that question. That's the only thing I'll ask. Just a tiny amount of pot of money. But I think what we really need to do is, because I know a little bit about what is the waiting list for patients suffering from GTPS plantar fasciitis. I think if I can work with a team to say that how long are they waiting for? Is it worthwhile actually intervening in them at a particular point in the waiting list, which we can relieve the waiting list for our podiatry clinics, for our orthopedic clinics, then that might make it all worthwhile.
It's exciting times, and well done. Thank you.
Thank you. Final question, Andy.
Some more observations rather than questions. I'll start with just saying thanks to Nimit again, because Nimit, I've coerced Nimit before to come and deliver this talk to other types of clinicians within the health board, mostly as an innovation piece rather than the specificity of this. This is a great project, and this is where we need to be going across multiple specialties across the health board. From a clinical perspective, knees are really interesting. So we do a lot of knee surgery, a lot of replacements. The vast majority are for pain. They may or may not reach the criteria that our orthopedics colleagues say that they should be replaced. And I think it's fascinating with knees that our reported outcomes from patients are poorer, and that's UK and worldwide as well, that knee surgery is not always a panacea to becoming pain-free afterwards. And I think having other weapons in our armory is really important. And then the final one from my perspective, being on the wrong end of knee surgery in terms of my clinical work, having patients who are not deconditioned when they roll up for their intervention is really important. If you can live well longer, you are a materially completely different beast when you leave hospital after a potential replacement. So I think that's the sort of spiral we're in at the moment. Nimit's showing us the opportunity of what's available is fantastic.
Good.
Want to?
Yeah, just to finish. So I think, we have the evaluation of this is really important in terms of the opportunities of doing more of these and then the other options. And I think your evaluation is going to help inform that. Okay, so we absolutely will support you with getting that evaluation to make sure you make the right decisions going forward, because there's huge opportunities. And I just wanted to finish, I forgot to say in my chief exec report that we had eight of our nominations we put forward for the NHS Wales Awards shortlisted, which is, I think we had the highest number of shortlisted as a health board, which is fantastic. But one of those is this project, which was shortlisted under the NHS Wales Learning and Research Award. And I know it's already won a number of awards, Nimit, isn't it, in terms of innovation, but I think it's getting that kind of, come back to your question, that kind of Wales profile as well now, to make sure we share. And again, gives us a good platform to complete the evaluation and look at further opportunities. So I just want to congratulate them on that as well.
Yeah.
Thank you both for sharing your
Thank you. And thank you very much for coming in. Best wishes to Paul as well. And thank you for coming this morning. Thank you. Until now. Could we move forward to the report from Clive Gwent, and welcome Lisa. We've read the report. Thank you, Lisa. Is there anything you wish to add to it?
I guess just to take any questions really, Anne, and I just wanted to showcase some of the All Wales representations that have been made recently, because I know they've hit social media and key strategic partnerships. I just wanted to make sure we were all familiar and in the loop really. So collectively over the past few weeks, Llais has raised a series of All Wales representations that you'll be very familiar with. Firstly, around sepsis and the rationale for that. And I want to share really is that I pushed that as director for the Gwent area on behalf of Aneurin and Bevan in respect of the work and the campaign that was launched around sepsis. And I wanted to share that and acknowledge that across Wales in terms of good practice, but also to source how other health boards are being proactive around sepsis and if they are mirroring the campaign that Aneurin and Bevan are currently leading. So I wanted to share that really, and I think it's useful to have a balanced approach of when things do work and when things don't work really. So that is currently a piece of work that is ongoing. We are collecting all the results from the wider All Wales Health Boards, and I will share that with you as soon as we have the formal response and a further call for action. So first, just thank you to the team who worked with us locally around that key project. Secondly, yesterday you will be familiar that the independent review was launched with a statement around maternity services from the Swansea Bay cause for concern. That was released, and obviously there is learning attached to that. And again, across Wales as Llais, we have shared a series of representations across all health boards requesting assurance around maternity and NICU services. So I just wanted to flag that really because it's highly sensitive and it is very much at the forefront of influential people within Welsh Government, but also across our public and communities. And just the third area I just wanted to flag is the announcement, I think Nicola touched upon this in her chair's update, of the 120 million by the CABSEC. Again, it's generated some questions across Wales around the realisation of the implementation around this key statement that the CAB Secretary has put in place. So I guess I wanted to just highlight that on top of the report that was shared, because there are some real key areas that are being focused on and areas of change that are up and coming. So thank you to all that have fed into me across timescales, and I look forward to sharing the results from the All Wales pieces of work. So I'm happy to take any questions, Anne.
Thank you, Lisa. Thank you for your report. Are there any questions, Akmal?
Thank you, Lisa. Yeah, we were just going through the report yesterday as well, and you mentioned GP services and secondary care services as key areas. I was just wondering what kind of questions are being put towards the community, or how do you get that data in terms of what actually is there, and specifically from the point of our own health board here in Ireland?
Sure. In terms of our engagement, so we've engaged with 614 individuals across the Gwent footprint through active engagements to going into community settings, particularly areas that struggle to be heard. So our first quarter is concentrated in Newport, and we are now currently live in Torfaen communities, and we go into various community settings where we link with people, and we ask the open question. In all honesty, we don't want to frame or put thoughts in people's mind. What is your experience of health and social care? And that really does open up a very honest dialogue with people, and what is drawn from that are key people's stories, and for us what we've heard is GP continues to be the key theme that we are hearing. And I just want to keep that live really with yourselves as part of my update. It continues to be a key area of concern, not only with our community work, but also with our complaints advocacy. So, you know, we supported, there was 153 contacts around complaints advocacy. The highest number for us to progress to formal complaint was GP services. And we appreciate that it's a very difficult landscape. However, it continues to be a recurring theme for us in Gwent, but also across the wider Welsh footprint.
Thank you. Any further comments or questions?
Yeah, interesting report, Lisa, as ever. Interested in your comments about GPs. Of course, I guess in terms of number, we will actually see more complaints because you look at the numbers of people GPs see every day. I mean, it's a huge amount of people, isn't it? So I think that probably the numbers that we see reflect the fact that they are that the GPs are actually seeing more people. That's why more people are perhaps complaining. In a sense, it's one of those strange anomalies in the system, isn't it? But that being said, there are some issues we know in primary care that we're working on. I was interested to read the spotlight on pharmacies. That was quite interesting. I think we've also picked up some knowledge in the system about some pharmacies in terms of dispensing particularly. And I wonder for us in the health board whether it would be useful now to have perhaps a more detailed look from a board perspective, maybe a report to one of the committees about where we are with pharmacies, because the whole baseline of pharmacies have changed so much over the years. They're not as they were. I mean, we've had the common ailment scheme running for a while now. It would be good to have some information around that, looking at demands. I mean, what pharmacists are generally doing now. I mean, they play a very significant role in our community provision. It's a long way from where they used to be. So it's interesting to read that you've also picked that up. But I think probably maybe coming to the quality committee, perhaps having maybe a report about where we are in terms of generally where they are, where next, and where are the issues for us. So thank you for that. I think that's coincidentally, and I've also picked up quite a bit of noise in the system of pharmacies. So that's quite timely for us.
Yeah, no, that's really useful. Oh, sorry.
Carry on, Lisa.
I was going to say that's really useful to have that feedback. And I know I attended my first ESOG and access group meeting last month, and some of the natural conversation was around pharmacies, but also around providing looking at supplementary hours and GP access to those vulnerable groups. So, for example, I know a very early conversation started around how can we encourage GPs to provide outreach support to homeless communities, for example. So I think this is a beginning of a conversation, and I know that there are rumblings and you're having those open, honest conversations, and I hope you see and feel value us bringing in the kind of public thoughts and experiences that seem to mirror your internal rumblings for us to be able to look at solutions and ways of working moving forward. So I do look forward to those conversations.
Good, thank you. Thank you very much, Lisa. Any further questions for Lisa?
Vivek, hello. Thank you for the report. It's fantastic. I just was looking at, that you've done an initiative with the Salvation Army, and you have these homeless people who've got no advocate for them, and they are really blunt end of life, and struggling. Have you gained any significant insight into the challenges they face in accessing healthcare? Because, where do they get, how do they get appointments? How do they, even their initial interaction, that must be something which probably most people in this room probably don't know how that works. Thank you.
Yes, absolutely. So the session we've had multiple sessions with Salvation Army in Newport. It's kind of our intensive outreach engagement to really drill down and listen to homeless communities. And we must remember that homeless communities aren't just those we see on the street. Our homeless communities are those in temporary accommodation. We know are increasing, individuals and families. The hidden homeless, those who are sofa surfing, and I think it's quite topical, and I think it will be an area we absolutely need to explore further. When we teamed up with Salvation Army, and we're now teaming up with the Woolwich and Torvine as part of our outreach, they are absolutely sharing some of the things we take for granted. So the ability to be able to make an appointment, the ability to have a support worker attend the appointment with you has come up as actually a barrier. That they're not able to feel safe and comfortable by taking someone they trust with them, around people going without treatment of open wounds because they can't access the treatment, about the barrier of when they enter emergency services departments of having to put in a home address when they have no fixed abode. So all of these questions are coming to light. So what I'm trying to do with the team is pull those together in a way that would be helpful to yourselves to start to think about how can we really make our services more open and inclusive, and what needs to happen, what needs to change. So that is a piece of it we're absolutely focusing on, and I'd like to bring back to yourselves and to the Regional Partnership Board around voices and areas of change.
Thank you. That would be very helpful, Lisa. We look forward to receiving that. Are there any further questions? If not, thank you very much. Thank you.
Thanks, Anne.
Can we move on to 5.1, please, the long-term 10-year strategy? Now, obviously, we've had a number of discussions about it as it has been evolving, and this is clearly an outline of the themes to inform a strategic intention and strategic direction. I know we're all desperate to see okie doke, so how do we put it into action? Well, that's in part reflected by the IMTP, but I'm sure Hannah will be able to enlighten us further.
Great. Yeah, thanks, Chair. As you said, we in May we shared the content of the strategy and sought some feedback on that, which we, as we committed to at the time, we tested and got feedback from other areas and stakeholders, internal and external as well. We alongside that, we'll come to the Shelley's item next. There's the work on values, which is a really key part of our strategic intent about how we take forward, how we operate, how we take forward some of the ambitions as set out. And we've done the work on branding, which you'll see and want to secure approval of today in terms of the paper. I did at the May board, so again I won't repeat, talk about our process we've been through to develop the strategy, not only engaging with yourselves importantly, but with our stakeholders, communities and staff. And just to repeat what I said at the May board, so the strategy is our statement of intent. It's sets our direction of travel. It points to the principles and the conversations we've had about our ambition to reorientate and rebalance, maybe to focus as much on the health and well-being of our populations and communities as the quality of care and the sorts of innovations we heard about at the beginning. So it seeks to rebalance that. And as you touched on, there is obviously a keenness to get into the detail. So assuming or following approval and endorsement today, and we've already started this work about sort of strategy deployment. So what's the delivery plan that underpins this? We've set out some high-level milestones in the plan, but as the covering paper says, that is the intent to bring back the delivery plan alongside the outcomes framework. So how will we know if the actions we're taking are moving the dials and setting us towards these high-level ambitions? What metrics will we track? And it will also set out, because, you know, it's one document, a strategy, whereas we're a huge organisation, and we talk a lot about our enablers, or as we call them in the strategy, our keys to success. So we will set out in that delivery plan the timescales and milestones for the underpinning work and supporting plans, whether that be estates, I know we talk about a lot, or the digital strategies that Paul is developing and leading on. So that will set that out in terms of that roadmap. And it will also, you know, obviously our IMTP, again, I touched on this in May, is a key articulation of our delivery. It's a big delivery vehicle, or sets out the specifics and milestones. So our IMTP continues to be a key kind of place where we get into some of the more granular detail. So I'll pause there, recognising we have talked about this a lot recently, and we're keen to move to the next phase. So yeah, happy to take any questions there.
Thank you, Hannah, and thanks to your team and to David for helping in determining this. Are there any questions or comments about the strategy, Tracy?
Just a word of support, really, because obviously this has started to be talked about in the partnership space as well, and how it can underpin and direct some of the work that we're doing across that strategic partnership landscape. And I think what is unique in what we're doing here is taking that longer term view, which I think is really, really helpful, particularly around the wider health and wellbeing perspectives, and setting a strategic direction that stretches beyond normal cycles, that sometimes restricts your opportunity to do long-term planning, and having conversations both with council planning departments and also education and social care, and real opportunities about how we can build safeguarding into this space and the wider safer communities element, particularly around things like drug use, domestic abuse, and those other things that we see that we have social harm that aren't necessarily explicit within this plan, but is a real enabler to enable us to plan in that wider strategic direction around prevention of harm and not just prevention of illness, which eventually will lead to greater equity within our society. So it's just been an amazing enabler for me from a public health perspective. So for me, I hugely welcome it and thank the planning team for going in the direction that we have done.
Thank you. Thank you. Any further comments, Akmal?
Yeah, thank you, Helen. Thank you. This is my first meeting, so
Yes.
I haven't been involved in the other previous sessions, but the 3 points that I just wanted, if you could just elaborate a little bit, not too much, and that 3 areas states, the digital strategy that you mentioned, and the workforce development or things that we could get some more assurance on.
Yeah.
I know these are all these intents and that framework is there, but just to get a little bit idea as to what we should expect from a strategic point of view. And especially this morning was an eye opener in terms of innovation. How is that coming through? Because I think if we are cited as the second most cited people in orthopedics, I think it's a great opportunity. So how does that strategy really relate to what we are doing?
Yeah, so yeah, thanks for the questions. Good question. So it touched on in my intro when I talked about those the next level of detail in our enablers, we call them sort of internally, but in the document we call them keys to success. And I guess example, just starting with the last one you mentioned in terms of workforce. We had a session, I think it was it just last week, on the next iteration of our people plan and how that is going to be framed around, it's going to be aligned to the strategy, but it'll give that level of detail from a people perspective, whether it's about the recruitment, retention, the skill mix, the wellbeing agenda. So you will see coming forward the detail, which I know people are really keen to see, of what sort of set the strategic direction. Because then when we know, we can then, when the detail comes forward, we can hold the mirror up to ourselves and each other. Is this in line with what we said in terms of the sort of organisation we want to be? So estates is a big, is also a big priority. We set out in our plan to develop that for this year in line with and set the timescales around the strategy. And Paul has got a suite of digital strategies that are in development again to support the ambition and provide that next level of detail. So there's you'll start to see, as I touched on, the strategy deployment plan will set out the timescales for the various elements coming together. And R&D's an important one. I on top of my head, I haven't got the latest. I don't know how recent our R&D strategy is, if we brought something recently, but under the better care theme in here, we set out our intent to do more of that. And it doesn't sit, the strategy doesn't just sort of sit with me in my sort of lane, so to speak. It's hopefully through many of the agenda items today and the stories you've seen, and as Tracy's touched on, the work that she leads and is doing in the partnership space, it all hangs, it comes back to that and hangs into that. So we'll be seeing more detail in those enabling plans, and I think it's our sort of challenge, as I said, to sense check that against the strategy as we move forward.
We have got an R&D strategy. It's 3 years now.
Yeah, it was 2022 to 27. So by the time I do some of those others, it'll be probably quite fitting.
Because I just wanted to make a point, Chair, if I may, that it is a 10-year strategy. And the way things are, the things are changing so fast. The demands of our patients, employment, inclusive of technology, and that's really quite a challenge to cope up with that. So I was just thinking that what's that space or headspace that we've got to be able to cope up with the changes. You know, the AI is coming, majority of things are going to be virtual. How are we trying to reduce this cost efficiencies and things? I think these are the kinds of things that, at least our level, that we need to see how that strategy is working.
Yeah.
I completely agree, and I think I'm so pleased to get to the point with the strategy, because I've been in the health board for 11 years, I think it is now, and even though we've had a clinical future strategy which has served this health board really well, it's been around since the consultation document, I think of 2007, I think it was. But we've never actually had a strategy that's written down and articulated in the way this is. So if somebody says, oh, can I have a look at your clinical future strategy? There isn't a document in this form that you can pick up and just double check that, other than this consultation document going back some time. And because it very much articulated a direction of travel that has stood the test of time over about 18 years, despite the change in landscape. So it is about making sure the strategy is sufficiently high enough level that we don't lose our vision, as Tracy said, some of the work we've done around where we're trying to go, and isn't then affected by the changing landscape and some of the other issues we talked about last time. But it's robust enough and high level enough that it keeps us on track and enables us to respond. So, and we can adapt. So our IMTP is our 3-year plan, which is and again, we need to constantly check, is that in line with our strategy? Are people plans refreshed? So for me, it's a really important, and I'm just really pleased that we've got something that we can almost kind of is our bedrock really of where we're heading. So first of all, having a document which articulates that, and I think takes us on 10 years and more from, you know, how far we've come, but is now the right point to go into that wider population health space, which this strategy does, I think, from where we were in terms of what we've achieved on clinical futures. I just want to kind of remind ourselves that we haven't actually got, you know, something like this to replace, really.
Well, thank you. It is reassuring to be in that place. Yeah.
Any further questions?
Yeah, just on the point about digital. So we have started development of that. You know, what we're going to focus on a number of areas. Well, first one is around the foundations. So we've got to get our digital foundations right. Otherwise, we can't take advantage of the new technology. So that's around not only our infrastructure, but our data as well, and making sure we are capturing things digitally. There'll be a focus on an electronic health and care record. That's not just for our staff, but that's also for our patients as well, and how we can work with the NHS Wales app. There'll be a mission around how we support our wider staff through the use of digital tools and innovation. And most importantly, what we propose to bring is a strategic partner on board. That's a long-term strategic partner that can help us navigate the changing landscape, because as you mentioned, it is going to change really quickly. So how can we leverage new technology such as AI, but in a manner that's safe, that's got patient safety at its core?
Any further questions? Yes,
Can I just make a comment? It's a huge project. It's holistic, isn't it? It covers every aspect. But I just wondered, what next? What will the next report, how will that be shaped? Will it be in the form of an action plan, or, you know, an implementation plan? How will it be shaped? So what can we expect?
Yeah, so in the paper sets out in the September board, be the strategy deployment plan with the outcomes framework, picking up some of those elements we've just talked about in terms of where the next level of granularity is, where the focus is, in a bit of the detail, and the milestones to the underpinning plans as well. So that's the intent, to keep it. We're all keen to get into that space as well. Now we feel we've got the scaffolding. We just want to move forward into detail and deployment as well. Yeah. But it's just getting that North Star set first.
Almost excellent. I thought it was really clear, and I like the information as well on the each of the areas within Gwent. And I just wonder, looking at underpinning all this is prevention, and it's talked about a lot, but there's not the funding allocation given, so as I can remember, from Welsh Government in terms of or additional funding. I'm just wondering how this is all captured within the prevention agenda and whether there is sufficient funding. You know, it's it seems to be a priority, but it doesn't seem to be a funding priority, if that makes sense. And the other thing I just wanted to ask as well is about GP appointments. I mean, is that on page 59? Is that number accurate? If there's 13,518 a day?
Yeah.
Between in a year. Yeah.
I mean, because when we had the, and I can see for our colleague from Life, when you get feedback on GPs, and we actually see in 13,518 a day, you know, a number of the number mentioned of people going to see their GPs and having a chat, which is, I think, what you were saying earlier, Phil. I mean, that does put things into perspective, really, is the amount of work being undertaken. And again, that day in the life of the Aneurin Bevan is really, really interesting for the public to understand and have knowledge of that, those figures there. So it's just the prevention part I want to know. Is there sufficient investment in that area of activity? Or are they talking about it? Are they doing the talk, not doing the walk, if that makes sense?
I think there's two ways of looking at the prevention agenda in terms of the costs. It shows up in multiple places. So you've got the money that could go in to put the interventions in that could be classified as prevention interventions. But then you've got other things that happen in the system like value-based healthcare, which is in effect prevention, because you're looking at doing things in a more, although that's looking through a financial lens, what it is looking at efficiency of care. And although that's probably classed as secondary prevention rather than primary, it gives you that sense. I suppose in the same ethos and spirit that the plan has been created, I think the plan is very ambitious, the strategy is very ambitious, and that's been in our gift. I think if it had been designed in a template from Welsh Government, it possibly wouldn't be as ambitious and as far-reaching as it is. It probably wouldn't have the prevention lens that it has got. I think that is down to our bravery. And I think the same prevention, investment in prevention, that is also down to our bravery in terms of how much we want to do that shift. But we've got to obviously do that within the envelope that we've got. And that is the challenge in terms of we can't ignore the demand that we've got. And
well, exactly. I mean, I think
so
that's the challenge. I've been a great supporter of the Marmot sort of concept, and I think that doesn't come for free, and I just want to make sure that, you know, we are able to address that. And the other thing I wanted to just follow up on what you said was, I thought that the 3 values that were mentioned there, which is kindness in how we care, integrity in how we act, and respect in how we connect, doesn't cost a penny. And I think those, to me, if we can share that, particularly with young people, actually, well, the whole of the population, that's our values. I think that's really quite a shining light.
Well, we'll come on to the values in the next one in case there's any tweaks on that. You want?
Yeah, really clear report. Absolutely, with all of what we have in there is what I call framework rather than detailed kind of strategy. Couple of things that strike me as being slightly out of our control, but we are totally dependent on, which is one, training the kind of medical professionals that we need in this place, people who actually do the work, accountants aside, obviously, but there's another one over there as well. But in terms of a 10-year strategy, obviously it takes at least 10 years to train somebody when you're capturing that GCSE and A-level degree and all the rest of it and bringing them through. That's kind of outside our hands, but it's something we are totally dependent upon for that 10-year view, if you like. Are we linking into whatever is happening nationally? And we've always been criticised as a country for not having a proper development strategy for professionals in a lot of fields, but especially the medical field. And the other one probably is the IT bit, because there's a lot that we get, probably is the wrong word, inflicted upon us. Or maybe it is the right word. It's not really. That again is outside of our hands, but we are totally dependent upon. How are we going to see what the 10-year plan is around those 2 bits, and how does that feed into this? That makes sense.
Yeah,
it's a bit of a rambling.
Yeah, no, it's helpful, and there are in this ambition there will be risks, won't there, and interdependencies. And I'm sure Shelley and others will come in, but there is, you know, we do work closely with HCIW, who run the commissioning of our professionals from medics through to, well, all professionals. But do we have, I mean, I don't know the current outlook. I can't remember how far ahead we are in terms of the commissioning strategy, but there is we need to continue to work with HIW on influencing, developing. We have forums and opportunities to do that in terms of helping to shape that. But that will, as well as other areas, there will be obviously elements of risk in terms of our ability to deliver, which we need to call out, acknowledge, and then work through what's the best way to mitigate them. Not least there'll be a change in either way, there'll be some sort of new government next year, won't they? And it's how what the strategy can do is sort of keep us focused on course amidst some of the noise. So we are not an island, whether it's locally with our partners, local authorities and third sector, or our national bodies who support and lead in some areas. So it's going to have to be about how we use our voice in that space and our influence.
It's almost developing now, trying to get somebody to develop, because we saw the chaos that Cardiff kind of, with their threatening closure of the nursing college bit.
Yeah.
And it may have been political, depending on how you look at it. But yeah, it's how we implement and bring in those bits that, we see coming up in all committees around, this is nothing we can do about it.
Yeah. There's a great concentration now on refreshing the 10-year digital strategy, because time has gone past and technology has advanced, and we really, certainly from the sales point of view, that is one of the top priorities, to get it into a shape for the future. Jenny?
So just to add, I'm obviously more attuned to the nursing sort of future projections, but some of the work we've done in NR in Bevan is to take some responsibility for that. So I think although universities and schools have an impact, actually as part of our social duty and as a responsible organisation within a foundational economy, I think we have a duty to try and look for the workforce of the future. So some of the work we've done with Shelley and Sarah and others is to try and encourage people into the workforce. And
So I still comment in the care section around trying to get people in from a community, but it's that almost the formal approach as well, kind of thing, which is slightly out of our hands.
Commissioning of places is one thing, but you need to go back a stage to when people are young and in schools, or working with our population around local access to educational opportunities within healthcare that not only help us to bolster the workforce, but help us to provide that role around our social duties and our encouragement of the population to say health is a really good career, here are the benefits, and isn't it exciting the opportunities that we could bring. And we've had real success in our recruitment around healthcare support workers. I think with a change in the way nurse education works, particularly for AB in the future, I think we'll have real opportunities to widen participation and encourage other people who wouldn't normally think about a nursing career in. So, my mind is already 10 years ahead about how do we have the right workforce for the population of the future. And I know HEIW are focusing on that because I'm leading a piece of work for them on the future community nursing workforce. So we know that, we're going to shift services into the community. That will be, an increasing trajectory. So the work I'm doing for HEIW is to say, well, what is the community nursing workforce we need? And therefore we go back a step. What are the right students we need? What are the right, opportunities for people to enter nursing? So I think it's all part of a whole, and I do think we've got some control and opportunity, but it's very much a partnership approach.
I was going to say, and that's the kind of piece I was trying to tease out really is, we've got to capture people.
Yeah.
Now, 10 years ago for people coming into the workforce now, of what part of this strategy for me needs to be in capturing people in schools and capturing hearts and minds so that they go through the right development. And of course, to get them into the roles here, I love a totally different field. She's already had 2 visit factories and 3 days of work experience in there, and she's going through all that good stuff.
Yeah, a question was raised around the affordability of the funding around this, and I think there's 2 elements. We are subject to external parameters, particularly around our allocations and our funding streams. But we're also subject to our own decision making around shifting resources. So if we do want to shift resources, I've described as upstream and potentially dehospitalising care, some of that is within our gift. Now, the external pressures on us at the moment and the additional funding we've got coming through, predominantly non-recurring, as most of us know, is to do with acute care, RTT, surgery work, outpatients work, which isn't necessarily where our strategy, Clinical Futures or the new one, which is very closely aligned, wants us to get to. So there is, I think, a reflection in terms of the decisions we make as a health board at strategic level, NTP level. There is that reality check around the Welsh Government, more specific here and now targets that in effect don't align to the future aims of the or actually Welsh Government. So there's a challenge there for us to do what we can internally, as well as recognising the external pressures and where the resources are being directed.
It is important to influence externally the things that we regard as priorities. And I think there are some elements of the Welsh Government allocations that will help that, because we've just had a note about how much was spent in Wales on the winter pressures and the individual schemes. Well, we could use that as a sort of real lever, an additional lever, to be able to move our agenda forward faster, not particularly in some of the areas that they say, right, there's X for this, but you know, that I'm sure we've got an opportunity underpinned by data and outcomes to say, right, we think actually this will be a better outcome for that money.
Yeah, absolutely. I think, and it's something we talk about in executive around push messaging rather than receipt of directions. There's an element as well of the creating headroom for improvement.
Yes.
Resource perspective, which at the moment we are very, very challenged on because of the savings agenda we've got.
Quite.
So, yeah, quite a challenge to do.
It is. But we're on the right track. Are there any further comments about this? Are we happy? Oh, sorry, Sharon.
Sorry, and I was just going to come in terms of the HIW point, because I think it's very helpful to have the various workforce plans to enable the strategy. But you're right too, and they're not 10-year plans, they're relatively short term. And so our people plan that we'll bring to September board will talk about all of the things that you've just said. So widening access, how do we engage with schools? But I think one of the main challenges for us in Wales is that we don't have a joined up national workforce plan. We have a workforce plan for nurses, we have a workforce plan for doctors. So I think in terms of that as a challenge for us, it's something that we need to think about.
Sorry, Neil, I can't see you out of the corner of your eye.
Yeah, I just wanted to add that I think it's very reassuring to see the development that's got into this already. And my analogy would be, I think this is a little bit like a road where we're constructing a road taking us to the destination. But along that road are going to be all of these inevitable sort of obstructions and rocks and things in the middle, which I'm hopeful that we're actually going to create enough agility in our activities so that we can navigate around those inevitable challenges to our progress. But at least we're getting the tarmac on the road, and hopefully the vehicle is going to be agile enough to stay along.
Good. Tracy and then David, and that's it.
To stretch the road building metaphor, I think what we have to remember, and I think both in terms of the workforce and the wider conversation, is we do have policy frameworks and enablers in this, in terms of we do have the Future Generations Act, and we also have the ambition to become a Marmot nation. The 7 principles of the Future Gens Act and the 8 principles of Marmot actually give us permission to do exactly what we're setting out to do. And I think within that is the foundation economy and building a workforce fit for the future to enable the fact that we have fair access and a thriving community. So I think we actually have all the ingredients to actually achieve what we've set out to do within our strategy.
Final word, Gavin.
Yeah, two quick points from me, one of which is obviously there's a set of guiding principles in the document, which I think are really important to call out again. We haven't talked about them for quite a while now, but those 10 principles I think are really important in terms of setting the longer term direction and dealing with the roadblocks and rockfalls and unexpected events that come up. Particularly things around continuous feedback and being able to change our direction if something changes around us, and the fact that this is an ongoing thing. So I think it's going to be important to hold ourselves to account with those guiding principles as we go along. And then the very final thing to say is just we've said it in the previous board meetings, but we didn't come to this with a blank sheet. We came to this with a blank sheet of paper. We didn't come to it with a pre-formed report, and a lot of this has been developed from talking to a huge number of people in our community. And I think it's really important we pull out again just to say we haven't just written this and said, here's a document. Do you like it? Like, does this make sense to our community? What we started with was talking to the community and asking them what they felt and what they wanted, and that's where this has come from. So it's got backing from an enormous number of conversations. At least 10% of our population we've talked to on this, which is more than any other health board in Wales. So I think it's really important that we just reconfirm that this is not a document we've just produced ourselves. This has got a lot of input.
Thank you very much. So are we happy to approve the final draft of the strategy? Yeah.
Yeah.
And we note the proposed approach for the launch. I hope we're going to ensure that we have people invited who can comment on the elements, you know, and would endorse them. Good. And we look forward in September to seeing the development of the first of the delivery plan. And thank you very much, Hannah, and your team. It's been a huge amount of work for you all, and well done. Thank you.
You're well done.
Could we move then to the values and behaviours framework, Shelley, please?
Jane, I think Paul gave a great introduction earlier by saying this paper is not going to directly cost anything. So I'll talk us through just some key highlights, but very intentionally, we've been engaging with our staff and community and partners around our revised values and behaviours framework, which will just be one enabler of the 10-year strategy that Hannah's just talked about. By way of background, our current values were introduced in 2016. So for those who were around 9 years ago, and they're often known as the 4 Ps. So people first, personal responsibility, passion for improvement, and pride in what we do. The paper, as I said, contains some key highlights, but primarily what we've found over the last 14 months is there's a disconnect between the values and some of our staff who found that there was a lot to remember and resonate with. And there was also an emphasis on the values being primarily for patients, and staff perhaps might have been a slight afterthought. So we've tried to rectify that with the proposal. Some people asked a valid question in terms of the purpose of organisational values and behaviours, and the answers that we gave was quite simple in the sense of values should inform all of our decision making, whether it be in this forum or right through to bedside and direct patient care. But fundamentally, it provides the foundations for our culture and how we interact with each other as people and staff within the health board. We've already touched upon the 3 proposed values, so kindness, which includes being kind to ourselves. And why I emphasise that is one of the key messages that came out from the listening phase was around our own health and well-being. So kindness, integrity and respect. And subject to our discussion and approval today, we'll move into the launch and embed phases using a see, know, feel, do model to integrate our values into the way we work. We'll also look to complete a cultural maturity matrix regularly or consistently as we reinforce the values across the health board. And then to finish off, I guess, we'll look to triangulate how our values has had an impact through metrics. So there will be some obvious metrics, whether it be within workforce and OD, if we look at grievances, disciplinaries, our staff survey results, there will be some obvious metrics there. But there will be some other metrics more broadly around things like complaint themes, for example, or quality and patient safety indicators, which we'll work together with Jenny and Hannah to determine as we evaluate how they're embedded. That's all I wanted to say, but happy to take any questions or comments. Thank you.
Thank you very much, Shelley. It's a well explained document. Any comments, Akmal?
Sorry, thank you, Shelley. Yeah, I think it's great to refresh the values, and really that is something that we all need to get that culture alongside ourselves to be able to walk the talk in terms of the 3 areas. I was just wondering if you did mention about cultural matrix, which I was trying to find how it is going to be measured. So I'm glad that you mentioned this one. I was just thinking in terms of relating this matrix with the data that I think Paul had mentioned earlier on. Are there going to be any live points by which we can determine on a day-to-day basis or a weekly basis to be able to see things are moving in that respect, integrity, and kindness? So how are we going to measure what's the data that we are going to be collating? And is there going to be any live data that we are going to be looking at, which can give us that reassurance that we are on the right track?
Absolutely. Perhaps not live in terms of daily or weekly data, but absolutely in terms of touch points throughout the next 12, 18, and actually beyond, say 5 to 10 years. Just talked about the 10-year strategy. This won't be introduced overnight. Whilst we'll be doing some educational workshop, and as I said, see, know, feel, do, so we'll be sharing the values. We will absolutely measure the trend of data. I think what we've got to decide is the precise data that we want to measure and what we feel will add value. So I've talked about there will be some obvious things that we can measure quite quickly, but most certainly I think we need to decide with Paul, Hannah and Jenny and James in terms of what raw data we want to measure and at what periods. So yeah, absolutely, because otherwise how do we know that they're making a difference?
Thank you.
Ewan?
Yeah, I'm glad you brought up the measure, because that's the one thing I was coming out on this, of what we expect to, because this is, I would assume going to make it a better place to work. Not that we're bad, but we always take it up a notch. But around those measurements of data, what we excellent. The end of it. So things like, as you mentioned, complaints and absence rates, etc., etc. When would we be able to see, once we've accumulated the data, where we want to get to with all of these things? Because we're sitting on a couple of unsatisfactory audit reports as well. They're speaking of SAFERY and all of these bits and pieces. When would we be able to see, this is what this looks like and this is what we're aiming for?
So this will feed in directly to our people plan. So our delivery of our people plan, which will come through to September's board, will give us what we think we're aiming to achieve in terms of what our baseline is now and where we see our improvement. In terms of speaking up safely, that would be a key indicator, because as you said, we've got some system issues to work through when it comes to recording speaking up safely complaints. But yeah, September.
Ella?
Thank you. And just thank you for the work that's been done in producing this, obviously, and good to see engagement rules. And I liked your document, which does explain, give very practical examples of how to demonstrate kindness, integrity, and what not to do. Yeah. So it certainly spells it out, because obviously this should apply from all sorts of, domestic staff up to the consultants and across the board, isn't it? So I think it's a helpful document in trying to get those messages across, because certainly we've raised it before, some of the issues on complaints is often communication and how that's handled. So this, I think, is a very practical document that people should be able to understand quite easily. And also, if you are in a discussion with a person where behaviour is not quite what you want to be, then you can perhaps refer back to this and highlight what they should go away and read and think about and reflect upon, perhaps in the future. So thanks very much.
Thank you. And we aim to bring it to life with staff stories as well. So yeah, thank you.
Jenny, and then Paul.
Just to add in support of Shelley, we've obviously connected into pillar 1 of our revised approach to quality staff experience as well. So we're beginning to connect up staff and patient experience in a way that enable us to take a rounded view of people's experience in the system. So it will also come through in terms of our quality strategy and approach, as well as the people strategy, because none of this is linear, it's all connected. So we very much started those discussions, and we've created a community of practice for staff and patient experience, so people can come and talk about their experience, and we can start to look at strategies to improve them, because they are interlinked.
Thank you. Paul?
I think just to say, you know, well done to the team for putting this together. I think there's been, if you look at page 84, it talks about the thorough engagement, or through the engagement, with nearly 7,000 people involved in the feedback, which I think is important. And I think now is the time to refresh, and let's keep things very simple. And I think, you know, if you say to people what are the key messages with those three key words, I think that sums it up. And I think, Helen, you put it very nicely when you said about that this is from ward to board. The whole thing can be sort of joined up. So from that point of view, well done.
Thank you. Paul?
Yeah, it's good how we bring all the various data sources together, because there's lots of systems out there where we're capturing this type of information. We've got the NHS Wales staff survey, for example, but there's also how we capture the heartbeat of the organisation on a daily basis. There's obviously some things you could potentially do in the future around that. If you know, been through an airport recently, you'll see those machines at the exit point with a smiling face and a sad face, and just touch it as you pass. Just how can we use different methods to capture that, how the organisation is feeling on a daily basis?
Absolutely.
Top on the digital priorities.
Marks and Spencer does it.
Yes.
I just wanted to very quickly add to what Paul and Shelley you mentioned, because it's the perception, you know, the reality could be all of us, we're doing what we are doing, but the perception is very important. That's why I was saying about the data is so important, to be able to get that perception right of that kindness, respect, and integrity. And I think that's a piece that we really need, these touch points, as you mentioned, to make sure that that information is disseminated through our comms team, through our examples, through our case studies, and wonderful work that we're doing. There's, I think, ample goodwill that we've got amongst our patients and their families. And I think that's the lens that we want to look at alongside the staff, of course. So I think that perception needs to change. Yeah.
Thank you. So are we content, please, to approve the proposed framework? And we look forward to the results and the action plan. Thank you. Thank you very much, Shelley. Phase 2 budget setting, Rob. Ooh.
Thanks, Anne. I must apologise. Ewan's just picked me up, and we haven't put in the detail that the CIP stands for Cost Improvement Programme. So if anybody else, I'm sure that's what it stands for in this paper. So the March we approved the IMTP and approved the initial budget setting, and agreed a two-stage or two-phase approach to setting budgets. So just as a quick reminder, the phase 1 budgets were set on our rollover recurrent budgets that we had established in our finance system, and they were delegated out to budget holders. This paper identifies the second phase of that budget setting, which delegates the residual funding we have available in context of starting the year aligned with IMTP. Part of the reasoning for doing it 2 stages to have some headroom to consider how the £40 million savings plans and some of the indicative costs identified in IMTP are likely to land in the new year, but also where there's a potential for saving, so that aligned with good budget setting practice is fairness, equity, and ownership of the budget holder in terms of budgets that are being delegated under their control, and obviously to live within, to make sure that aggregation and consolidation, the health board has a balanced financial plan.
So several options have been considered. We've worked on various approaches. Ultimately, in terms of delegating the balance of the £40 million that was available, we've identified a £1.9 million reserve to deal with specific development propositions that were identified in the plan. Again, there's been a review of that, and we'll continue to review those, and through the Chief Executive team, they will be refreshed. But in terms of the overall approach, looking at all the options, the most equitable option and to achieve the reasonableness test and the ownership test, we've landed with a 2.2 cost improvement programme expectation for each budget holder based on their IMTP spend plans. What that in effect means is that we are delegating budgets for predominantly all the cost pressures are identified in the IMTP by every budget holder in a corporate building. But we are requiring, aligned with our £40 million savings requirement, everybody to find 2.2% saving against their proposed spend. There are some flex and stretch adjustments, particularly minor. The most obvious one to note would be the facilities adjustment is slightly more than 2.2% because of the emerging energy pricing adjustments. So that, again, it's stretched, but we can see a line of sight to that delivery. The table in the paper identifies how that lands for each budget area. So there's a very small reserve to manage developments and any explicit cost pressures. Other than that, the expectation is budget holders will live within these budget levels if the board agrees. The other thing to note is we do constantly have allocation adjustments coming through Welsh Government, which will be reflected through the earthwork normal processes and delegated as appropriate. Most notable at the moment, as I mentioned earlier, actually is some of the waiting times money we're having. So those elements haven't been factored in this budget setting plan because this is, if you like, a reset of our start point.
Thank you. What happens if the budget holders do not operate within their limits?
So we have our performance framework that's established for managers and budget holders across the health board. It includes wider elements in terms of quality, performance and finance, and we are taken through that route, which ultimately the first step is a trigger point, which is forecast deficit in excess of £1 million. And then we hold specific deep dive meetings to work through explanations for the cost drivers, what's driving that position, actions that have been taken, actions that need to be taken, and any corporate support that can wrap around that.
That's good. Okay. Any questions? Akmal?
Thank you, Chair. Sorry for getting into all of these things because I was trying
All right,
to get.
that's what you're here for.
Thank you very much. Thanks, Chair. Thank you, Rob. I think it's great to see the overall plan. I think it was just following up with the question from the chair with regards to firstly, what happens if they don't really spend within the budget. But equally, I think it's important that you mentioned about 2.2% of savings if they can show or bring to the table. I know it sounds small, 0.2% in the larger scheme of things in the budget, but is there a table which perhaps we can see that what does that 2.2% equate to in real numbers?
Yes, I can share that.
Yeah, to be able to understand which maybe clinical division or department is doing or at least attempting to do something about that 2.2%, because I think that is going to be a huge contributor towards bringing our budget in balance.
Yes.
And the deficient budget that we have got. So I was just thinking that that would be things, and that, how does that link with the first question as the chair asked in terms to the governance piece? Because I think large part of this would be going into procurement of some kind or the workforce. So in that case, what are the sort of the steps taken to be able to be absolutely sure that that service or the product is needed and which is not compromising the quality as well? So I think there's a piece in the governance section, but equally some innovation within those budget holders to be saying, okay, we in 6 months' time, if there's a gradual trajectory downwards to reach that 2.2%, let's say over 12 months. It's not a big ask in my thinking, but in real numbers, I think that might be the answer.
Yeah, no, obviously, and there's that's quite a big question you posed, but we've got answers to them all, which is a positive thing, because of the last couple of years, we've obviously been in financial deficit. We've taken an awful lot of action, put governance steps in, put support products, and we've got an established value and sustainability board that meets every 2 weeks. That's a big name for a savings board. We've got every month we meet with the divisional directors and the execs that are in the table as well in terms of looking at performance and savings. Our core governance structures around our standing financial instructions, standing delegations, financial control procedures, expectations of budget holders in their job descriptions, their person specs, the sign off of budget letters, responsibilities around delivery of performance as well as finance to get that balance, is all part of the, I could go on, but I won't, is all part of the control framework and the expectation of delivery. In terms of tracking that, so I can share, we've got wider analysis. There's just a very concise table in the report, but I can share that on the board. That's no problem at all. The aim of what we've done for this year, which is different to the last 2 years, is we are not holding a central deficit reserve. IMTP identified savings requirement that we felt was reasonable in comparison with previous years. Yes, stretching, yes, ambitious, but budget setting and delegating all budgets out. And the way we've done it means that we aren't having to keep a track, if you like, of a delegate position and a corporate position, and gives that line of sight and clarity where really the cost drivers are linked to budget. So we're making the budget the control. In the last couple of years, we've sort of almost set budgets as control levels whilst holding a negative reserve, which is representative of our overspend, which isn't something that we particularly wanted to do, but we recognise there's a journey to reduce our ask on the budget holders. So hopefully that answers your question. I'm very happy to pick it up separately. I know we have already.
Yeah, we did. Thank you.
Just want to talk about our journey really, because I think that, you know, when we look at the current challenges that we've got with regard to, this morning inflation was increasing, we've got pay, we've got costs, we've got utility bills, we've got food, estates, materials, green agenda, all these things are increasing, including the increase in patient, what patients are looking at. We have got structures in place, which I'm just sort of reflecting on when you said what you said earlier, Rob. Structures in place. We've got the culture and ethos now with regards to, you know, ensuring that our budgets are sort of, you know, we are working or trying to work within our budget. And you mentioned flex and stretch. I just want to ensure we're on secure and hold, because my concern is that we could go over budget. We've just been sort of given some indication that the Welsh Government have felt that we are sort of doing more with our budgets to keep it within the sort of current demands, etc. So what can the board do to help and assist you to ensure that we do all we can to keep within the budget framework?
I think in terms of where we previously discussed this, it's not me, it's the whole organisation, isn't it, that needs support in this, but there's a rigor around what we've got set up as processes, controls. If those aren't generating the required outcomes and outputs, then we need to consider where the opportunities are. We've got a process around that in terms of identifying opportunities. But I think there's also the piece around, as we progress through the year, and to a degree we'll be picking this up in the finance report, and I think maybe later in terms of the risks that we're experiencing now and compared to the plan. And I think there's a debate around our ask on the services, but there's also an expectation of control and ownership of delivery as well. So there's, I think I haven't answered your question specifically with we should do 1, 2 and 3, because I think our overall framework is spread out and allocated to look at everything we do. But part of what I've described in terms of the earlier question around our frameworks, holding account performance delivery, and understanding that needs to deliver solutions to hold our break even. If it doesn't, then we need to revisit what our assumptions were and our delivery capability.
Yeah, I think there's an opportunity to reflect on what we've gone through, and also then to think, right, well, what we now need to do in the next phase, which is we need to do what we can to keep within the budget. I think that our responsibility as a board is to, the budget, I mean, there's £1.83 billion for our community, and what we want to do is to get the best effect for that on members of our community, and particularly with the patients and staff, etc. And what we have to look at is what, is affordable, and particularly with any other schemes elsewhere, where we maybe have to contribute, we have to look carefully at our budget and think, well, what's going to be best for our patients locally.
Yeah, absolutely.
Thank you, Paul. Any further questions? If not, we'd be happy to approve the budget delegation. So, look over.
Thanks to the staff.
Thank you, Rob. Yeah. Could we move to 5.4, transforming access to medicine, South East Wales Hub? Rob, can I ask you to start, and then I'll bring in Jonathan, and welcome Jonathan, who is the Clinical Director of Pharmacy, to present this case.
So in Jan's absence, as a quick introduction, this case, or this obviously is a proposal to establish a new pharmaceutical facility under the Control of Shared Services. It's part of a wider programme, but this is particularly around the South East Wales requirement. So transforming access to medicines is part of a wider piece of work which has identified a need in Wales to respond to a threat around the available capacity of specialised drugs. I'm sure Jonathan can explain the technicalities better than that, but they're basically specialised drugs, particularly cancer drugs. And the paper is included in terms of requests a support from the Health Board for the outline business case. It's important to note there's an awful lot of work that's gone into this programme already from across Wales. It's very complicated. I'm sure you can see the actual document is very complicated, and hopefully this cover paper does sort of outline in summary terms what it means for the Health Board. There are issues that need to be resolved from moving to the OBC to the FBC, and they are documented predominantly around clarity around staff moves, the residual staff for the Health Board as well, as position in the plan, and also reflecting that some of the future costs need to again just be revised. Normal process moving from an OBC to an FBC, updating the baseline staff point because it's based on 23-24. There have been some significant price changes in 24-25 that need reflection. Plus, this will affect some pharmacy staff as well. So there's a whole HR process to be recognised around that to finalise where we are. The proposition describes sorry, John, if I'm taking over what you're going to say. The proposition describes a broadly cost neutral position for the health board. Is a slight saving. I think given where we are at this OBC stage, I describe it as emerging as a cost neutral in terms of the offering. There's some offsets in terms of privately procured drugs that will be supported, provided through the TRAMS mechanism. I think there's a wider debate to note on the Velindre facility as well, because we need to test what the best option for provision of drugs how Velindre works. We are the commissioner as the health boards, and we need to consider what's the best value in its wider sense for that. So that's again something that will need to be picked up in the move from OBC to FBC. I'm going to stop there, otherwise I'm sure I'm going to do John. So I'll leave it there with you, John.
Yeah, thanks, Rob. I think you've covered quite what I was going to raise today. So, as you said, that the first stage of the TRAMS programme is the South East Wales hub. There's been a lot of work already in terms of the radiopharmacy, which you'll be aware of because a previous case was approved there. So this does form a national programme with 3 hubs across Wales eventually. And I think, as Robert said, this is really business critical because, as the case identifies, the rising demand of cancer treatments at 11% per year is going to mean we're going to exceed our ability to produce those in-house by 26-27. There's a lot of outsourcing of cancer treatments currently, as Rob mentioned. So the idea of this new facility will be to repatriate those treatments. And the costs of the unit is the savings are from bringing those back because of the ability to manufacture at scale and without the on-cost that outsourcing currently has. So that's the key reason why this needs to take place, to provide that additional capacity, resilience and contingency for our service. I think it's fair to say that although we have invested within our aseptic services, our last upgrade was in 2019, the life scale of these units is only about 10 years. There is significant inspection from regulatory authorities because of the nature of what we do there. Our unit has been upgraded in terms of its risk from low to medium recently because of the capacity and the throughput of the unit. So the TRAMS programme really is a little bit too late. You know, the quicker we can get there, the better, if I'm honest. As Rob said, there's been a lot of scrutiny of the case through a workshop that was held with shared services, with finance, pharmacy and workforce representation, and all those things that need to be worked through in advance of FBC preparation have been identified in executive summary.
Thank you. Any questions? David?
I think so. I'm absolutely comfortable with the premise of like repatriating things back in house, having a shared centre for South East Wales. I think that makes absolute sense, and I think it's definitely the way we should be going. And I think the business case makes it clear why we should be heading that direction. But I've got a couple of frustrations about the case, which I think makes this really difficult to sort of approve in its state. The first of which is this has clearly been a known problem for a long time. I mean, the programme business case was approved 4 years ago, and it's taken until now to get a case here. And in that time, we've gone from it being a problem and a known issue to it almost being too late to do it. And it really 4 years is a really long time to get to this stage. And I think that puts us in a position where we don't really have a choice about whether we approve this or not. It's where our back is against a wall, and if we don't approve it, we've got a problem. And I think we've had this on a number of business cases coming through to us over the last couple of years, where we don't really have a choice but to approve it, because otherwise we're going to impact our patients. And I think that's a big problem for us as a board, to be able to have a reasoned debate about whether or not this case actually offers the value for money that we think it offers and provides a service we want to have. And so I'm really frustrated it's taken that long for this case to get to us. And given how quickly it's got to move forward, when we're expecting this to get approved today, the aim is for full business case by the end of a financial year, and within the next financial year after that is when we're expected to reach capacity and have problems. So that doesn't leave us long to get a full business case through to us, have a proper debate and discussion about it, design how the service is going to transition, get the service operational and switched over and starting and bringing it in-house. But because it's taken so long to get this case to us, the time to actually deliver this and make it work is substantially reduced, and I think that's a big problem, and brings with it a lot of risk. But the second problem that I'm really concerned about is the costs. And this is again another reoccurring problem with some of these cases where this business case does not cover the full cost of actually making this service work. Right now, it's a case for setting up a facility and kitting out facility and staffing the facility, but does not include any of the costs that sit around that in terms of actually making it a viable, workable thing. So there's no cost in here for the staff that are going to need to be retained in an Iron Bevan to actually handle the transport or handle the receipt of the medicines that are created. There's no cost in here for the actual transition. There's no cost in here for decommissioning our existing facilities. There's no cost in here for the clinical trials element, which was part of the sort of the case for this centre. So it's incomplete. There's not enough information in this case for us to actually determine if it is a cost neutral case or if it's a really expensive case. We can't judge that based on these costs. Because we've got that duty to manage public money and make sure we're spending it effectively. We can't do that on this case, and there's not enough information or reassurance to us to actually be able to tell, is this an appropriate case? Is this a worthwhile case for us to approve? And so I think we need to make sure in the next stage we've got that so that we can approve it. To avoid this just being a rant about all the problems in this, because I have reported the lack of local costs I have brought up time and time again in these cases. We've had it with pretty much every national business case that's come through to us where it only covers the cost of setting up a facility and not actually making it work. I think that before we approve this, I think we need some guarantees that firstly the full business case is going to include all of those local delivery costs. And if full business case does not include the cost of actually making this work and a viable service, I don't think we're going to be in a position to approve it. And secondly, I think we need to have some guarantee that we're going to receive this business case with enough time to have a proper reasoned discussion about whether or not it is the right thing to do. I think if we don't have that and our back is up against a wall where we have no choice or the whole thing is going to fall apart, then I think we're going to have a problem. And I think we have been there before. We have a business case turn up in the March board right at the end of financial year that desperately needs to get approved, ready for funding next year. And there's always a note accompanying with it saying, if you don't approve it in this meeting, the whole thing's going to fall apart and our patients are going to get harmed. And I will be really, really upset if that's where we get to in February and March. So I think we need some guarantees that's not going to happen.
Thank you, Gareth.
Can you respond to that?
Yes, please.
So I'm not sure the detail of how it's been worked out, but I can give you a broad
Does Jonathan want to elucidate?
Go on, John.
Yeah, I mean, I think that there's a few issues. Clearly, 4 years, I think everybody would agree the timescale is too long here. I think we've got to reflect back in terms of the pandemic during this time, the amount of work the shared services were doing for delivering individual drugs to support our nurses on wards, the COVID vaccination program, all of those things the shared services team doing. The radio pharmacy unit and the closure led by the MHRA in Cardiff led to massive challenges for us in terms of nuclear medicine, and all that work is currently being done by Swansea on behalf of all of South East Wales. So the priority about establishing the radio pharmacy unit has got in the way of the rest of the Trams case. I think that was a necessary thing that needs to happen. I think, you know, we recognised, and the people that went to the workshop, the challenge and the risks that were identified. There were 80 odd risks that all of the health boards in Bilingtra identified, shared with shared services, which we've now had, you know, commitment that they're going to be worked through for the full business case. And there's a set of workshops with stakeholders to do that. So I think it is, for me and my colleagues, directors of pharmacy across, it is the only show in town. You know, and we are committed with shared services and the stakeholders to make sure that information is available for a full business case, so that proper decision can be made.
I think that the thing is we are we've had a conversation about we have financial issues. We are at budget. We don't have money to spend, but we would like to spend, and I can absolutely understand that in this might be the case where we want to spend the money on it, but we need to be able to make the decision with the full understanding of the facts. And currently, say the way in which his business case is set out only includes the cost of establishing facility and not the cost of actually making it viable and working. And if a full business case does not have that in it, then I don't see how we can approve it, follow our duty under value money and public funds.
Nicola? Yeah, just to add, so completely agree, Danny, that we had a detailed discussion at executive committee before we agreed to bring it to the board, and we've been in dialogue with other health boards as well, because we recognise there are gaps in you to give us the full confidence. But I think on the balance of risk around the patient risk and the commitment, this has to be teased out with full before we bring the full business case back, where you then press the button on the investment. Then we were content that there was sufficient transparency about the risk and our expectations at the FVC to recommend that we obviously, given the critical nature of the risks, patient risk around cancer, to progress absolutely with the understanding you just set out. And I wouldn't bring it back as an FVC to the board without those issues being addressed.
I think it would be helpful if that formed part of our response. We recognise the deficiencies of this business case and wish them to be addressed.
Yeah.
In the FBC, if it's part of the board's minute, it's stronger.
We've had this before
I
with
know
these cases, and we keep saying that the local costs have to get included, and then we come back with cases that aren't. So if this one does come back with the costs included, I will be happy.
Yes, I think we'll all be happy.
Yeah.
Unique, hopefully costs included that are offset by, yes. That's the ambition in this case.
Yeah.
That we will do that as part of the FVC.
Rob?
Yeah, just again, from my knowledge of this, I've been involved in the detail, but I do sit on the board as the DOF rep, just oversight of it. So a couple of things in terms of time is delayed, just to flag that the programme has had quite a significant challenge landing a site, South East Wales. So that's delayed things definitely. They were going down one route that was nearly there, and then it didn't happen. So that, I would guess, probably added 12, 18 months delay to getting where we are now. And in fairness to the programme, they spent a lot of focus on how facility will work. And as you can imagine, it's very complex around different organisations doing different things. So I won't go into that, I'm sure you appreciate all that. But one of the big issues has been, and it leads to your question, to be honest, Alan, is around, so what do we need residually in each organisation to make it work? Key part of that is around, well, which staff are likely to move under 2P regulations, and where does that leave us with our functionality being clear on it? Decommissioning our facilities I hadn't thought about, so that is something to think about, but we'd have had that either as a refresh or anyway. But I think why it is probably not giving that in the notes and the caveats that we've written in the board paper. I think that transfer of staff is critical for the clarity of all those points you've raised. Yeah,
I think it is.
Thank you. Anything further? Are we happy then to approve the outline business case with our concerns about the absence of a comprehensive cost analysis
Yes.
not being included in this, and we would wish to see that in the FPC? Yeah. Why is Velindre different?
Doesn't need to be, does it? I don't think.
I don't think
We're
it
gonna
needs to be
We're
different.
gonna need to just test that.
Yes, can we test that, please? Good, lovely. Can we have a 10-minute break? Thank you, Fiona. On items for discussion. 6 was a public engagement on the development of Neville Hall Hospital.
Thank you, Chair. Just for any new colleagues in the room, just to recap that the development of Neville Hall is one of our key strategic priorities in our plan. Case for change and driven really by the prevalence of RAC, so the reinforced aerated concrete, that we need to manage the risks associated with that. So as part of that, our response to that, taking the opportunity to think about the future of Neville Hall, so the investment can bring other benefits than the key benefit of removing RAC. So yeah, that's just a bit of a recap for the colleagues in the room. And the business case process, as we went through at a recent board development or board briefing session, is the 3 business case stages of a strategic outline case, outline business case and full business case. And we are at strategic outline case for Neville Hall and have a well worked up strategic outline case ready to bring to you. But as you'll know, a key part of that is part of the way we want to work and actually the regulatory framework that we have in Wales and obligations is to engage continuously through the processes of developing service changes and or investment cases with our public, our communities and our staff. And in line with that requirement, we are now engaging with our public and staff around the case for change, around the principles, around the direction of travel and around the emergent thinking that we shared and we tested with colleagues at that recent board development session. So the purpose of the paper today is just to bring you an update in the context of that engagement plan, working very closely with Lisa and Slice and Karen and our comms and engagement team. And so the paper, I won't go into the detail conscious of time, but the paper sort of sets out the approach that we're taking to that engagement. It's 8 weeks. We're already well into that. I think we're coming soon to midpoint of the process. It sets out the various ways in which we're engaging, both through meetings in sort of more traditional way, not just in the immediate Neville Hall and Abergavenny area, but stretching out into all the communities that access and flow into Neville Hall. It's really important we complete our coverage in that respect, and also using surveys, as I said, the events and social media and other methodologies. So we do have, we are following engagement plan. We've got a group that Karen chairs that are driving that through with engagement documents that set out the level of detail you'd expect to see for this stage of the process. Just to say, it's not in the paper just because of obviously timings, but we had within the first 2 weeks of going live with the engagement plan and approach, we've had over 200 responses, survey responses, which is a lot in 2 weeks. We have now had 3 events, varying degrees of the further sort of you get away from Neville Hall, there seem to be less people coming, but relatively good attendance. There's one last night in Tredegar, because obviously colleagues from populations from Tredegar flow into Neville Hall, and we have a series, as you can see, set out in the paper of events coming up that we have senior JIRA colleagues as well as clinical colleagues supporting those conversations. Early themes coming through, which is we're not at midpoint, so this is sort of very sort of hot feedback rather than the mid-review feedback we'll get, but is especially through the surveys, is an understanding of the case for change, an understanding of the principles, clear, as you would probably expect. People want more detail, more clarity, and it is that fine balance, because on one hand, in line with our obligations under the regulatory framework, as well as what we know is the right thing to do, we want to engage throughout the process rather than wait to the end and ask people what they think of a fait accompli. But then some people want more detail now. So it's just, that's just the experience, and that's the nature of engagement. But the early feedback is positive and supportive in terms of what's being proposed and discussed. Where there is some of the, I don't want to say negative, but the maybe more challenging reflection is less about what's being proposed, and it's more about current experiences. So bring back ED to Neville Hall. That's the sort of coming through strongly on social media, and to an extent at the events, but not interestingly through the surveys. So we are pushing surveys, and really helpful some of the networks that we developed and built further on from the strategy work we talked about earlier. We're really using those, and that network of community groups, interested individuals to really push the survey and push the engagement. So yeah, so the purpose, I'll pause there, happy to take any questions, but was just I wanted to spend a moment just to remind colleagues of where we are in this process. Note that the engagement is underway, we're coming to midpoint, and bringing the strategic outline case forward. And I think whilst we've got a well-developed, very thorough SOC. We do a bit more testing internally, but I think it will be beneficial for us to bring that forward, having completed this first engagement, in terms of sort of any future challenge or suggestion that we haven't been listening to colleagues. So I'll pause there, but happy to take any questions.
Thank you. And just to add that Nicola and I will be seeing Powys Health Board and Monmouthshire County Council to listen to their views as well as part of this this part of the process.
Yeah, thanks for that, Chair, because whilst there's the list of sort of the public meetings, there's a lot of those sort of conversations happening as well, and we're meeting with Taff McGann colleagues. Yeah, there's quite a detailed programme of interactions planned. Thank you.
Paul?
I mean, very, very helpful. I think the media coverage just talked about investment at Neville Hall, which I think is very, very important. And just one question, all this, I think, applauding all that's there, just to ask the question about all this is compliant within the sort of Welsh Government policy and procedures, because if there's any issues, then it will be, have we followed policy and procedure to the letter?
Absolutely.
Just assurance that that's been followed.
Absolutely.
In terms of due diligence, really. And,
yeah, okay, to answer that. Yeah, absolutely, and that's why it's important. We've agreed the timescales, the approach with DICE, and we will be, when we get to OBC, we'll be moved to, there'll be either sort of more formal engagement / consultation, depending on the nature of the changes where they actually land. So yeah, this needs to be a continuous process rather than a sort of a one-off event.
As well as the variety of opportunities that's there in terms of sort of the website and social media, and also the fact that there's face-to-face meetings and also team meetings. I think it's a good range of opportunities for people to be engaging in this discussion. And then we get the report having, ask the community their views.
We'll have that as an appendix to the
Thanks. Well done.
Any?
Yes, just to say that I really welcome the proactive approach, because up to now, I think in the past it has been more reactive, and that has caused all sorts of problems. And this is really welcoming, because I think the number one thing that the public want is reassurance, and the detail doesn't matter as much as the reassurance that it's continuing.
Yeah.
That Neville Hall will be there for them, and I really welcome it, and I look forward to meeting you. Next week at Monmouthshire.
Well, don't ask nasty questions.
No, I won't. I will declare an interest.
Yeah, of course. No. Any further comments on this? Thank you, and thanks very much, Hannah, for the team's hard work on this matter.
Just thanks to Slice and Carrie.
Yeah, and to Slice. Thank you. 6.2, the winter plan.
Sorry, me again.
Don't worry.
So the purpose of this paper is to colleagues, again, those who were here will remember that in January we bought quite a hot reflection of winter. We were still looking back, it does seem strange that we did, because we were really still in the throes of it, and we did have a really challenging winter for a number of areas. So the purpose of this paper is to sort of complete and finish that review through a data assessment of the data and information, and also then look ahead to next winter. But this isn't just, again, just to sort of in terms of managing the item, this isn't the winter plan, that comes to September, and I'll update on some further information and asks we've had through from Welsh Government just this week as we develop our winter plan as a help with partners. So yeah, that appreciate the paper is quite long, so I won't repeat all the detail in it, but just to note, the upfront section really looks back on the data in terms of the demand against how we predicted or modelled it, either at a national or at a local level. And I think the key message is that the flu, the surge in demand was earlier than the modelling, the national modelling anticipated or the scenario suggested. The data also shows that in terms of our uptake of a number of those vaccinations, whilst we did outperform other health boards in Wales, it was still lower than we would have liked or anticipated, and significantly away from required herd immunity. And it's not a leap to suggest that that would have played into why it was such a challenging winter. We did work on modelling based on that activity, though that modelling sort of translated into our local scenarios around the numbers of beds or the capacity we would need. And the paper and the tracking of bed occupancy on pages 4 and the heat map on 5 shows that the reality was, for the majority, with the exception of Christmas week, we were at the upper limit consistently, sometimes over the upper limit of what we modelled. So, and again, that was felt with our staff and our patients, with the sort of delays and the pressure in the system. There's some positive stories in there in terms of the metrics, in terms of the pathway of care delays and the focus that had across the system, leading to a reduction in the pathway of care delays. But similarly, ED demand was on the higher side of our predictions, and sickness absence fluctuate, peaking in December, but did reduce back down to under 6% in March. So the data does tell a story about all of our experiences, really, in terms of how it was a real challenging winter. So, and lots to learn, which is really important to take forward into this winter. Some key reflections from the data: we picked up vaccination levels being low will be a significant focus for this year. Learning around that focus and partnership approach to pathway care delays and how that reaped benefits, but also some of our we've talked as execs and with operational colleagues about needing more sophisticated sort of early warning systems. What are the triggers that will show, give us the insight that the system is getting more and more pressurised. In addition to reviewing the data, we've held a lessons learned session with partnership colleagues, with operational colleagues as well. Bit of a chance for them to sort of share some cathartic experiences. And I know Shelley and I were talking about it a week with, from a workforce colleagues perspective as well, their experiences of managing through winter, which is really important to listen and hear that. So again, some of those themes are played out in the paper on page 8, changes page 10. Cutting to forward looking then, so through the lessons learned, we started to reflect on how we move forward, not just from a oversight and governance, where there's lessons learned in terms of a multitude of places. And I think we even touched on that when we were looking at the plans, that there's lots of different parts, partnership and base RPB plan, and then an additional system resilience plan. We made it more complicated than it needed to be. So there's a bit of learning around simplicity of plan, focus on additionality whilst driving the BAU, business as usual, and existing models of care. So 5 key areas for us that we are working at for the plan. One is around the vaccination programme. I'm sure Tracy will add to that, around how the timing of it, albeit some of it is influenced by national procurement of vaccines and the national plan, but timing of it, the targeting of it, and the campaign and the comms around it, both at a national and local level. So that's a key priority. The second is about proactive care planning with primary care colleagues with vulnerable patients or populations at risk. So we've got those care plans in place. We had some additional funding to do this last year, but we did sort of scratch at it really, and this the feedback is where we did it did reap benefits, but it's scaling some of that up. And again, looking at the data in terms of what's driving demand around falls and respiratory, so really looking at those pathways and linking in with our hospital to home models as well. So really not so much stripping back in a negative way in terms of, you know, not resourcing, but really confirming and shoring up those key pathways. And then finally, it's about the surge capacity in place. We spent a lot of time on planning for additional capacity last year, and probably made some decisions. Was the feedback from many in terms of too late around additional wards, which put us on the back foot on some of our workforce challenges. So getting more upfront and clearer in terms of the additional surge capacity we need within health. Just a bit of additionality whilst we continue to develop the plans for September board is we received on the 15th, can't remember what day that was, or 14th, a letter from Welsh Government with a toolkit, a winter planning toolkit attached, and a requirement to do a sort of assessment against that to help us in our next phase of planning, but with the RPB as well. So that is being commissioned and will start in earnest. That self-assessment needs to be back with Welsh Government by the 12th of September. So that will help us play into our planning going forward. And clarity about some of the additional indicators that we will be tracking at a national and local level. To I was going to say a new body, so it's sort of the Care Action Committee, some of the Care Action Committees, that's what I call it, the Integrated Community Care System Committee, replacing the Care Action Committee that the CAPSEC.
Not quite sure of its terms of governance.
No. Yeah, a bit more information due, we were told. And in addition, at a national level up front, it did come through sort of late in the day last winter, but is a very, in addition to the sort of service and capacity plans, very focused plan for those key weeks, the 22nd of December to the 13th of January, which is, you know, in terms of fosters cover, where we will be expecting surge. So that will play into our detailed plan in September as well. So I will pause there. I know you had sent a question in advance, so that you don't know what to ask it, so we can.
No, it was a side question about something else that was, but I did have a question about this, but.
Okay, so I'll pause there and leave it for questions. Thank you.
Do you wish to add anything about vaccinations, as it's so topical at the moment?
It certainly is, yeah, thank you, Chair. I think there's several things with vaccinations. I mean, Hannah's set out the wider process of this, but I remain really concerned about MMR. We're closer to herd immunity with dose 1, but we've still got quite a gap with dose 2. We've obviously had the sad news over the weekend that a child died at Alderhay from measles. You know, this is a vaccine preventable illness, and so the fact that we're having child deaths associated with it in this country is devastating. So we have launched a campaign this week to try and increase that. I did do my patient safety visit with Phil on Monday to the vaccination centre in Cwmbran, and looked at the art of the possible in terms of how we can utilise that centre. I mean, the work that they're doing there is magnificent, but I'm not sure that we are maximising the use of that and making sure we're doing. But it was brilliant. You know, a lady walked in while we were there and she was in the chair having her vaccination with about 30 seconds of walking in the door. It was just phenomenal. So there's real opportunities there. I think the timing around winter planning and the winter vaccines, I'm hoping this year will be more, it will go more smoothly. We had the challenge last winter that we were launching RSV and maternity in September. Whether that was the reason that flu and COVID was pushed back, I don't know, or whether it was availability of vaccinations, but we certainly know in terms of when flu was happening, we were behind the curve in terms of when the peak happened. We hadn't got maximum coverage as we could do, so I'm hoping we'll be able to get those winter vaccination campaigns started earlier. There has been a shift at a government level around COVID provision of staff vaccines with that. That will no longer be widely available. Health boards can make individual decisions about that. The advice from JVCI is that they're not needed, and if we did decide to run with that campaign, it would be at our cost. So there is a shift in that. There's also shifts happening around meningitis vaccinations at the moment, so that is coming on board. So there is a huge amount happening, but we are taking some proactive action. HPV, I don't think we've got back to where we needed to be in terms of those cohorts lost during the pandemic. We're willing to catch up on that. We did do a targeted exercise 6 to 8 weeks ago where we contacted the parents of those teenagers that hadn't been vaccinated. We've managed to get 200 through. We're obviously in our modern age, we have that. The digital age hasn't managed to get letters to parents' eyes any easier than we did when they were hidden in the bottom of bags when they were paper years ago. That end of term, oh, you didn't go on that school trip then, as we come across all of these letters. And it's clearly, it isn't a vaccine resistant situation, it's a lack of information and lack of awareness in terms of the information getting through. So that targeted approach has enabled us to get 200 children vaccinated that otherwise wouldn't be. So I think it's just about finding ways within the capacity that we have to try and do more and more of this and take greater opportunities around places like the vaccination centre, where we can see that greater footfall and really have an impact on the challenges that we're seeing in our community.
Thank you, Tracy. Any questions or comments, Ewan?
Yeah. Do we understand? Because obviously we set up for a certain level of surge when it comes through in the winter, and we set up for that. And obviously this year it went way past that because of what we model against. Do we know, or can we tell, what is an optimum level that we should be preparing ourselves for? Even if the model says it's slower than that, but if we prepare for that, where the costs come in on it, because obviously we staff a lot of this through bank and agency and all the rest of it. Is there a benefit for us for setting up on a certain level, or is it we carry on until the surge comes and then we're going to staff it anyway? If you see what I mean, or are we setting up for a level that if it doesn't hit, it's going to cost us? Am I making sense now? Is it kind of a rambling one?
Yeah.
Where the best place to set ourselves up for, ignore what the modelling says, that's your median case, and you just kind of plan around it.
So, and I think I understood, and I think, yes, there is, so regardless of the modelling and notwithstanding that there'll be things we can do, vaccinations, you know, the demand is going to come. And so we need to develop a plan that when the modelling and the national modelling comes through, we can test against it. So we are indicatively saying we think we're going to plan for 2 wards of surge, and whether that's surge on top of existing capacity now, or whether through the actions we're taking through 6 goals and our de-escalation plan, we try to bring capacity, you know, through reductions in length of stay down to then surge. That's stuff we've got to work through. But there's a plea from operational colleagues that we make a decision early enough to plan properly. There is, and I'm sure we'll get to it, there is a sort of a financial challenge in this at the moment. Welsh Government haven't confirmed that there's going to be any additional money. There's relatively small amounts in the RPB but there's not enough to cover demands across, and it'll be slippage money. So we do need to get ahead in terms of making some of those plans to work them up to surge, so we can just test whether the workforce, and from a value for money perspective, do more of it through bank or shorter term rather than premium. I mean, we had you know, medical who comes in for the surge ward in Royal.
So I'm guessing even if the plan said, or, you know, we're going to hit this massive spike coming up, even if we planned for that, or if we planned below that, the additional cost wouldn't have been any different, or if we planned for it, if you see what I mean?
Well, it depends on how we respond to where we put that demand. If we haven't planned in beds, the patients we could see our boarding position worsen, we could see impact on planned care. So there are choices for how we create that additional capacity, if not through.
Yeah, that's the piece I'm getting at. Is there a difference in cost then into how you plan for it? I assume there is.
Yes. Yeah.
And it's again back to that, what the optimal kind of.
Yeah, and we need to work through that for this winter.
That'll come in September. Do you want to add to that, Tracy?
Yeah, if I can, Chair. I think that there's wider implications as well in terms of how we can look at this and triangulate the local modelling with international modelling. And I don't think we probably were as good at that last year as we could have been. We watch the wave of winter illnesses. So if we watch what happens in Australia and then Canada, it will indicate what's going to happen for us. And that wave told us our peak was going to hit in December. Our local modelling told us our peak was going to be February. So I think there is something about having that global view in terms of the way respiratory illness operates during the winter months.
Do we not do it? Because that's been something that's been around.
I just don't think it was triangulated. I just don't know how it was. And the other thing that really didn't come to the fore was vaccine efficacy. So in terms of how effective was the vaccines in those that was receiving it, which again, if that efficacy of the vaccine is lower in a population group, you'll expect to see more severe illness. So it's how we can shift that. And the other thing that I think we need to be more mindful of is taking our cues from what's happening in the community. So when we look at the prevalence of respiratory illness in the community, don't wait for it to get into our hospitals. So we started to see the peak of this happening in mid-November. So if we'd have taken non-pharmaceutical precautions like hand washing, mask wearing within our hospitals, we could have stopped that spread into our hospitals. So there is something about understanding how it behaves outside of our buildings to stop it coming in. So I think it's all of those all together that can make a real difference in terms of trying to flatten. You won't cancel it out. It's going to happen. It's going to come. Yeah. But there is stuff we can do to actually try and get ahead of it a little bit and just dampen it down. You won't wash it, like I say, but we can squash it a little bit.
Yeah. That's kind of where my question is coming from, is what that optimal bit of, if we push this bit, does that impact somewhere else, or, you know, what do we prepare for?
You want to add to that, Jenny?
No, just to add to what Tracy has said, I think it is important to look at community prevalence because it will give us an indicator of when we should introduce measures. I mean, we were the best health board in Wales last year in terms of hospital-based transmission because we had additional testing, and we did go earlier than other health boards on in terms of mask wearing and additional measures. I think the reflection Tracy and I have had with our teams is we can probably push that even further and be more proactive in that phase of when we know community prevalence is rising, but it's not yet in our hospital system. But I do think that, you know, when we did enter that phase, we reacted well. It was just a little bit too late. So myself and Tracy are working on how we make those decisions proactively together earlier to protect the system.
Thank you.
Mark?
Yeah, thank you, Chair. Yeah, well, some of it is already answered.
Okay.
So both Tracy and Jenny. The main point, obviously, that is what I was going to ask, is that how much is our public health involved into prevention and being proactive? Because I think that's where the issue is in the community before they land at our door. So I think that is something reassuring to know that you are there, because the vaccine, the advocacy, reach out, that is going to be there before it really happens. The other thing which I wanted to ask was in the strategy of winter preparation, being a Marmot region, and I think you mentioned about the RPBs, but the PBS and all these other platforms that we have, how much can we involve them? Because I think it will impact into our hospital, whatever, as Ewan has mentioned, whatever we plan, it still can just go, a bit pear-shaped. But if we are also getting other partners involved, as you're saying, right at the beginning, and what contingencies we can really help to highlight so that there's less pressure on us, only the medical conditions, but the others, they could be treated in the community or housing or whatever that else is needed to be able to do. So I was just wondering if there's a communication or a conversation going on at some point.
Yeah, I'm happy to start and then others will come in. So we do, and we'll be taking winter plan. We'll have sort of our organisational winter plan, of which part of it will be our plan with our RPB partners, through how we're maximising some of the existing schemes or capacity or services, but also what additionality. So a lot of what we did last year was through the RPBs. Yeah. So and indeed the sort of communication that came in this week I referred to, that response needs to be a response from the RPB, not just from the health board. So it brings opportunity, but it also then brings challenge, because our staff are the, I know Tracy made a point about vaccination, but we have staff sickness, social care staff sickness, those key 2 weeks I touched on earlier, they're really challenged in social care as well in terms of availability of staff. So we do come at this absolutely from a partnership. RPB, I think maybe interesting comment in terms of the PSB, maybe it's about how we use those partners, particularly on some of the agenda, particularly vaccination, but we do have it will be a joint plan of it, recognising we'll still need some sort of health specific actions.
No, just to build on that, it was a really interesting conversation that came at the patient safety visit on Monday, in terms of that one public pound approach. So there are real opportunities for us to have greater presence around preventive health, vaccinations and those kind of interventions, even hypertension case finding and those kind of things. One of the barriers we have is how we can access our community assets. So what we often see is buildings that are most relevant to put in these places in are often owned by other estates than health. It could be owned by local authority, it could be owned by private sector, and the rates that are applied to them become prohibitive with using those sites to be able to do something within the communities. So I think there's a conversation that needs to be had at a PSB level in terms of recognising the wellbeing services we want to provide in our communities and recognising that they are our communities, regardless of what organisation we're employed by, and how we can work together to make those assets available to do the best wellbeing interventions for our communities. So I think that is a conversation that needs to be had, so that we can start and get into that territory of one public pound, whereas at the moment we're a little bit protectionist in terms of how that operates in practice.
Thank you.
Bill?
Yeah, great report, Hannah. I thought, reading the kind of final version of last year, and it's a bit like a series of novels, isn't it? Really, with the plans, just to kind of pick up where you left off from the last one.
Well, we wish we didn't have to.
Yeah, well, I know, but it's good reading though, I think.
It's going to make the Times bestseller list.
It was coming.
Yeah, it could be a Netflix series, maybe, perhaps not. So great work in terms of reducing delays, I thought. I mean, and there's a lot of blood and sweat going into that, I'm sure. That hasn't happened easily. The way position we were in and where we've got to. I think that's some really tremendous stuff in there. I guess the question now is, well, what has really worked well? So what do we need to do more of? Set aside the other question, well, what didn't work? So what do we not need to do? Really? I guess that's where you are.
Yeah.
I guess in the discussions.
Yeah.
It will be interesting to see how we enact this Welsh Government idea that the Regional Partnership Board must be much more involved. It'll be quite interesting to watch that develop, I'm sure. And the other, I guess the question is, what are we going to do about this 60% of staff who are not vaccinated? We are a health organisation and we've got 60% of them walking around who have not a needle in their arm. And then we look at sickness rates and the sickness rates go on the roof. I'm sure there is a correlation between low level vaccinations and high sickness rates. So I guess we need to find a way through that. I mean, I don't know why we can't mandate it. I know everybody will say, give me 10 reasons why we can't. But I would think if you're running a health organisation, you want to be able to say to your staff, you have to be vaccinated unless you have a health reason not to be. You don't have a decision. That's sounds a bit harsh, but it just seems ridiculous that only you're looking at, we talk about the public, and yet the people that we employ, the vast majority of them are not vaccinated.
Tracy?
This isn't scientific, we're all applauding you, Tracy, so not tested in any way. But some of the conversations I've had around that has been the fact that by the time vaccines were available, they were already frantically busy. And then being able to, vaccines weren't always readily available in the place where staff were. They didn't have time to get to the place where vaccinations were made available. So there is something about reenacting, and we're doing this now, is looking at flu champions again, so we can walk towards. But I think when you are trying to vaccinate staff when they are facing a firewall, which is what was happening, we were trying to vaccinate staff end of November, early December, when they were just flat out, already sick, already under capacity because they were carrying the colleague sickness. Whereas I think if we can bring the vaccination service forward September, before we're in the mouth of the monster, I think it will make a real difference. So I think early opportunities around this is absolutely key to this being more successful. Again, it's not foolproof, but I think it happening earlier will make a difference.
I mean, I respect the busy argument, but I don't buy it. I mean, everybody that's got a job these days is busy. You know, talk to the checkout operatives in Tesco or the Amazon drivers, you know. But the fact is everybody's got a job these days are busy. But if you're busy and you work in health, I just think there's no excuse at all not to be having the right level of protection. It just seems nonsense. Really.
We just need to make sure we can take the vaccinations to them.
As long as we've got the vaccination, that's the issue. I mean, in fairness, if we don't have the product, well, people can't have it, can they? If we've got it, then I think we've got we need a harder push on, you know, saying
we need 50 Wendy Warrens running around.
Oh,
with
absolutely.
So jabbing bucket.
Lisa?
Penny.
Oh, Penny?
No, he's just answered my question exactly. So thanks, Phil. Very good.
Thank you. Thank you, Chair. Thank you, Anne. I was just looking, you know, at that modeling figure that you have shown, where virtually all these is in red, you know, it has gone way behind what was expected. And that is a huge challenge for operational teams, because if the model doesn't work, you know, all your plans fall apart. Has there been any work done in the modeling side, in that where does the model fail so dramatically? And, you know, is it just a 1 year that we failed in the modeling, or is it a year-on-year thing?
Yeah, so some of it speaks to what Tracy was saying before. Our local modelling took the Wales national modelling of the peak, and we took it, well, of course we took it in good faith, but we took it and we didn't really question it. And we took it and we applied that, whereas as Tracy's challenge is, we should probably look more critically at that in terms of what we locally know, and does it chime with, you know, through, you know, Tracy's professional view on what's been happening, you know, in the Southern Hemisphere. And so, but we sort of, and I think nationally, I think they're reflecting on that as well. And it's come through, I know, the chief exec conversations, but so there's something about the national modelling that's done, us being a bit more brave in challenging it and tweaking it to when we apply locally. That's really what puts us off is and by getting that peak wrong in the national model, and therefore we translated it and compounded it and it was wrong. We will obviously take, you know, so locally, you know, the shape of it was right. We were just, and typically when you model, you don't typically always work at the upper end. You might fluctuate a bit upper, middle, and if you're lucky, at lower end. But we will definitely, and I know so Paul in my team is already looking and sort of self-reflecting on what we can do with the local modelling. But it does come back to the two bits, the national, international, and intelligence as well. So yeah, we will refine. We have to learn from there. Yeah.
Thank you. Just one more additional point on that, you know, is that the modelling seems to be much more closer to the worst case rather than the prediction or the best case.
Yeah.
And is there an argument that for this year, or it is better to probably focus on the worst case. And as Ewan was saying, that will give you a little bit of operational freedom to be a bit more safe and have less of those emergency measures.
Yes, is the answer to that.
When you're trying so hard to put things in.
Absolutely, opposite about our optimism bias sometimes in those.
Thank you. Well, we look forward to receiving the winter plan in September. Given the worst case scenario. Yeah, thank you. 6.3, the Communications and Engagement Annual Report, Nicola.
Yeah, thank you. So I'll keep it relatively brief because the report is there with lots of information and Karen's on the call if there's any specific questions. This is our second year of the 3-year communication engagement strategy that we've developed. It sets out the activities, the achievements and some of the challenges the organisation's communication engagement team have been busy with. I think just to pull out one or two, so we've been continuing to try and strengthen our brand around communication with staff. The 1AB, we've been doing lots of executive drop-in sessions and we kind of reviewing that in terms of how we can continue to develop our visibility using different approaches. The online catch-up sessions with myself every couple of months has been really positive and a good way to get kind of the messages out, and we continue to use quite a lot with staff stories which get quite a lot of positive feedback. You can see how social media continues to go to the largest social media, which has got its advantages and disadvantages, but it's such an important tool for us in terms of communicating with our public. We've got such a wide reach in terms of 460,000 followers across our different channels, which is really powerful. And we continue with our engagement activities, particularly a lot of work was done. We use the strategy as a great opportunity to be out and about and picking up other issues as part of that, make sure we are visible in different parts of our community every week. And we mentioned campaigns for public messaging where we need to get really important messages out on Overall Street, and we mentioned earlier this emphasis one, but can have really powerful impact with some of those key messages we want to get out. And we build in our stakeholder kind of networks as well, with more and more kind of active members, and set up a kind of new WhatsApps update service for those again to have more kind of timely communication. So trying lots of new things, always more to do, and I know Karen and her team work exceptionally hard to think of innovative heuristics. I think we can never do enough, and I'd like to make sure we continue to spend more time around staff communication, picking up the values discussion earlier, because I think we can never do enough around communication, particularly within the organisation. Okay, thank you. Happy to take any queries.
Do you wish to add anything, Karen?
Sorry, just getting myself up. No, thank you. I think Nicola summed that up. I think another busy year with some really good things going on, but as Nicola said, still always more to do and some exciting things from this year as well.
Good, thank you, and thank you to you and your team for all your hard work in promoting us. Listening. Thank you. Any questions, Helen?
Just thank you for a very interesting report. Fascinating to see all these new methods of communication. I just wondered, what does a 1AB champion do, and do we know what impact it's having?
Is it okay for me to answer that, Nick? Yeah, yes, please. Yeah, no problem. Thanks, Helen. So 1AB champion is a member of staff that has come forward to say they want to be champion. We will share all the information with them directly. So we send it out, but we actually have them on a group. So we share everything that's coming in, anything new, what's happening, and we ask them to be the champion for their division. So what we find is, if you think of our nursing staff, our catering teams where they may not be on emails, not be on the intranet regularly, these champions go back into their division, their areas, and share information with them. They'll share our newsletters. They will pick anything up from the intranet or Nicola's catch up and go back and then make sure they share that amongst their teams, any posters, that sort of information. So it's really giving them sort of a feeling that they are involved with what we're doing, but then asking them to be sort of advocates within their department and division.
Okay, thank you.
Thank you.
Paul?
Just to say, I think that the data that's provided from the team, I think is phenomenal. I think it's fantastic work. But also to say to thank Karen and the team for the awards evening recently, particularly for the, because it's the first time we had the staff and volunteering sort of together. And I think you worked exceptionally well. And the volunteers I know have written in separately to say how much they enjoyed it. But if you look at the data, and the thing raised that I think Ewan raised earlier about careers in an Iron Bevan, there's been 78,000 sort of views on that. So I think there's a lot of stuff that goes on, and well done to you and the team for the exceptional work.
Thank you.
Paul.
Any further comments, Ewan?
Yeah, I'm just going to, I'm guessing the answer is no. Are we able to measure the value that we get from this at all? From, you know, things like somebody going on there looking for careers, or somebody going on there looking for health options, or what is that? Or just being signposted to anywhere else to save them ringing us, or to save them coming into some, or going to the wrong place and anything like that. Are we able to value it at all?
I mean, you're absolutely right. It is a difficult one to do, because obviously what we do, we've got all the hits to the websites. We know where people are going, what they're looking at. Whether they then take that up is very difficult to try and baseline. But what we do know, so what we are quite confident with, so through social media, for example, we know we get an awful lot of complaints that come through social media, either direct messaging or public comments that we answer and go through. And we do know that we actually shut those down at an earlier stage, because most of the people, if you listen to them and go back and say, thank you, we're really sorry, you know, this has happened, would you like to take this further? They normally say, no, thank you, we've listened, you've listened to us, we've got it off our chest, that's okay. Otherwise they would have gone formal with it. So we do know, we do sort of have value in stopping some of that. We are looking at on the website to see if we can get more analytics, because I think the difficulty for us is it's a national platform. So it's hard to try and focus in, but these are things we need to try and look at, Ewan, because you're right, it is difficult to say. We know where they're going, we know what they're seeing, but then do they actually take that through to the next steps by, you know, for example, the Gwent Health Guide? All the information's there about how you access our services, but it's hard to know then how many chose not to go to ED and chose to ring 111 instead. And that's the difficult part, I think, that we've always struggled with. And I know I was chairing the All Wales Directors of Comms Group, and every health board's saying the same. So we are looking at work to see how we can try and do something around that.
Yeah, I'm just wondering, you know, in the days of cost pressures and all the rest of it, is being able to justify, and I know it can be justified, or I would hope it can be justified at some stage. Well, there is definite value in it, but it's just justifying it is the issue, and how we measure
I think
it.
the risk is spending loads of money trying to justify it.
Yeah.
It's getting the balance.
It's almost getting those hits and say, you know, and being able to say, yeah, well, for every 100 hits, this saves us this amount of cost somewhere else.
It's not that, you know, we do look to measure where we can, but it's just not that easy with these stickers.
Yeah, no, that's, so I was guessing the answer is no, but
when we can, I think, you know, and as people start jobs, we could be saying, how did you find out about the health board? And if it says website or social media, so complaint to capture isn't.
That complaints data, for example, you know, it saves us a lot of time and a lot of cost if you can close it down straight away. But then there's a counter argument, oh, they probably wouldn't complain if they couldn't do it this easily, can you?
Yeah, no, absolutely.
Thank you, Chair. Karen, fantastic work. I just wanted to look, you know, I was just going through the various data there, and 98% of the visitors, you know, are English speaking, or their language is English. What efforts are we making for people whose first language is not English? And, you know, especially among the ethnic communities, is there a push for a slightly different way of approaching them, because they might not be actually getting all these wonderful messages and alerts, you know, and they are the ones which are the most hard to track or hard to approach, and especially, for example, for the vaccine initiatives and things like that. It is not an easy bunch to crack, so to say.
Absolutely, completely agree with you in there. So from the website perspective, we have Recite Me. So you can go onto the website and click, and it will translate it into, I can't remember, I think it's over 100 different languages. So they can access the information there. The difficulty, what you're just describing, is in our communities, and those who wouldn't have access to a website, or wouldn't go to the website, or wouldn't access it on social media. So from there, for those, we're obviously out in the communities every day through the engagement team. So we go into to some of our communities in Newport and across where language, sort of English isn't the first language, working with the support groups in those communities to try and help them that way. So we also make sure that when we are doing big campaigns of information, we get all the information translated. So we take them out, we share them through our stakeholders and make sure that they are receiving as much of the information in the language of choice that we can. It is a challenge without a doubt, and it's a cost, because every time we try to sort of translate, we have to, pay the money, but it's the right thing to do without a shadow of a doubt. So we are trying to do a lot more. Like, for example, in the last year, we've done a lot of events in Pill, in Maindy, in some of the sort of the places that the communities go to. And we always make sure we work with our partners who have the translators there that can work with them. I did the mosque in Newport myself last year, and it was brilliant. There's so many people turned up with so many queries that we wouldn't have had, or they wouldn't have asked or found out from before. So more that we need to do, but we are making strides.
Thank you. Thank you, Karen. Thank you. Any further questions? Just a thought, Karen, it would be, you talk about the powerful staff stories. It would be really great for next year if we can have a few examples of, and what did we change as a consequence? It would be really helpful.
Absolutely, no problem.
We can see the impact that makes. That'd be good. Thank you.
No problem.
And thank you very much to you and your team for all your hard work. Thank you.
Thank you. Thank you.
6.4, the performance report. Please, Hannah. Okay. Oh, you're working hard today.
I'm tired. Okay, so a long report. Just want to draw out a couple of sort of practicalities. Just to note, this is the first performance report. So same format colleagues are used to, but we're in the new cycle of the annual plan, that's INTP. So they're those trajectories and those metrics we committed to in the plan, so that you will hopefully note that. We've also added, because just to keep us on the straight really, hopefully help people navigate, little tags where the metric is specifically either an organisational escalation metric, a ministerial priority metric, or an enabling action from the planning framework. We are continually trying to make sense of the number of different sources and names for different priorities. So that's just well, hopefully help people in terms of that. So just to draw out a couple from each section, and then Shelley will draw out areas from the workforce section, and Jenny from the quality. But so prevention and population health, I just did want to flag that from no ministerial targets or priorities, we have targets for everything, but not tagged as a priority last year, to now having 4 under this sort of heading, and 3 in the space of vaccination. I was going to draw out a couple of vaccination areas, but I think we covered that. Tracy's talked about vaccination, so I'll leave that. But just did want to call out as well positive improvements around the Healthy Child Wales programme for the 8-week check. So that's great improvement showing there. Primary care, again, we talked about how do we better get a sort of a more comprehensive understanding of what's happening in primary care, recognising some of the challenges of metrics. And so whilst these are still quite activity based rather than sort of standards or outcomes, we are trying to strengthen our story around primary care across all professional groups. We did through the plan, and hence tracking it now. And I think it shows a largely positive story in primary care of how we're maximising the use of all resources. Phil touched on in the context of Lisa's report earlier, pharmacists, recognising the ask for some more information to come back, but we can see increase in activity around pharmacists' independent prescribing consultations. Again, a really important offer in the primary care sort of a suite of professionals. And we've previously noticed that alongside this, the Common Ailment Scheme, which pharmacists run as well. So whilst it's levelled off, we have consistently delivered high levels of activity there. We have got some challenges in some of our trajectories around weekend nurse contacts and also emergency dental activity. We did pick this one up in F&P, so just for board colleagues to note that we're digging into whether this is because it's demand driven rather than capacity available driven, but under the new contract reform, there are more urgent appointments available and under that, so it may therefore be taken away from the emergency dental element of activity, but we're just testing that hypothesis really. Urgent and emergency care shows continues to show a mixed picture. We know we're in external escalation, and that hasn't changed following our recent review. This report is May, and now we have June information since the report was finalised for papers. So in some areas, June performance is improving, and unfortunately in some areas the June performance did worsen after May. So, but ambulance waits, in terms of the number of ambulances waiting over 1 hour, May was the best performance we've had in a number of years. It's 672. Our June performance did worsen in terms of when you see the next report coming through to 720. But July, we have on our come on to actions refocused and regrouped in July to get that improvement back on track. It's a theme I know we have in terms of the improvements we make and really sort of embedding, as well as the number of ambulances over an hour. This year you'll see we're tracking the actual total hours lost, because in the previous metric, whether it waited 4.5 hours or 24 hours, it still counted as one. So clearly we need to be tracking the actual hours lost as well. Similarly, 12-hour waits, we made good progress in May. Best performance on this metric we've had for 4 years. And I'll come on to talk about the changes to some of this that we could potentially be piloting under some new Welsh metrics. I was going to draw out positive progress on pathway care delays, but I think we touched on that in the context of winter, but really important to note that we are sustaining that. So the June figure is 181. And just to remind colleagues, June 24, it was just under 250 pathway care delays. So real massive improvement. So credit to Jenny and the work we've been doing with partners on that is really positive. We know we've still got a number of key actions in this area, and it does remain a focus. The transfer lounge is up and running and starting to yield benefits, but there is definitely more opportunity for how we use it to unlock flow. Nicola in her update touched on the ED extension, which will be really important from a patient experience as well as capacity perspective, and disappointed that potentially could be further delays. And ED consultant recruitment made progress, although we noted at Safety Flow this week, we've got some long-term sickness now, which could knock a bit of that. The operational oversight has been enhanced. I said we'd sort of regrouped in June after it was challenging. So point of contact, senior point of contact, walking the floors and being the spot person. And we are from the date that decision was made, we can see some of the metrics changing already. And Nicola herself chairing now a Safety Flow meeting a month to give it that just additional focus and clarity of expectation, I think has helped. But still a lot more work to do. We are really keen to de-escalate, but more importantly, improve experience for patients and staff. Cancer, the May position in the report, 65.3%. Sorry, April 65.3%, May 64.2%. So we're stabilising and the backlog as well. So the number of patients over 62 and 104 days remains stable. The work of the task and finish groups is it's relentless really in finding those fine margin opportunities for further improvement. Planned care. So we ended Q1 having committed to Welsh Government on the back of additional monies. We said we were looking at around 345 patients waiting over 104 weeks at the end of Q1. We actually delivered 172, which is so significantly below the ask, dominantly in orthopaedics, but with a small smattering in non-cataract ophthalmology, and one in ENT, which it turns out wasn't a real one, which is really disappointing, which we'll pick up. So it should be 171, but Yeah, that's disappointing. You can see the enabling actions now in the report, which start to sort of draw out predominantly some efficiencies and productivities. SOS and PIFU, we are leading the way in Wales on this, and predominantly over 10%, and our DNA rates 6.6%. We did a bit of focus on this in the outpatient meeting, in the planned care meeting yesterday, about we still have variation between specialties. And finally, just mental health. It's great just to continuously be able to give the positive update around the progress is sustained and being delivered in the adult mental health parts 1A and 1B for over 6 months now. And CAMS 1A, there was a slight wobble due to some staffing issues, but that's recovered now for June, and 1B delivering the standard. We still have a challenge in psychological therapies in terms of low performance there, where we sort of turn attention has turned to in terms of any learning from the other improvements to translate across. And can't not mention ND, which continues to perform again best in Wales, and it is attracting interest and lots of visits for the team to come and describe how they've made those performances in the ND. So I think it's overall real positive direction of travel, with still some challenges, as you would expect in the urgent emergency care sector mainly. So I just want to ask questions there, or hand over on the workforce bit to Shelley.
Any questions? Helen?
I just want to acknowledge huge amount of work. Good to see progress in so many different areas, and obviously you know where you've still got to focus. Just a quick question or comment. One of the ministerial priorities is obviously to do with women's health hubs. I've not really heard much about those, and I'm not expecting you to tell me now, but I wonder perhaps could we have a briefing at some point about what our plans are, because it's got to feed in by Q4. And I certainly did an interview panel for an obs and gynae, and they were very vague about women's health hubs. So
Tracy's leading on that.
Happy for me to take so I'm the SRO for our Women's Health Hub, and Claire Lippett's in Sexual Health and Gynecology is the clinical lead. So we have set up and we have submitted our plan to Welsh Government, and we've got a meeting later this week to respond to our financial requirements around that in terms of how it's going to be established. So the Women's Health Plan from a Welsh Government perspective has set out 3 priorities, so maternity, menopause and contraception. So we'll be building it around that to begin with. I think as we go into the phase post-March, because obviously they're trying to get this embedded by March 26, so they're running quite fast on those 3 priorities. But I think there is real opportunities for us to take the ambitions around women's health plan and really look at women's health more generally. We know that heart failure and cardiovascular disease shows up very differently in women. We know depression and mental health concerns present differently in women, and also alcohol, life course, alcohol use in women is very different. So I think there's a real opportunity to that, but we're focused on their 3 priorities at the moment, and we are on track. We're very happy to bring the briefing back with you. That'll be helpful.
Thanks very much. That's very helpful. I think the people I met were obviously out of the loop.
Yeah, no problem. I'll get everything together.
Thank you. Any further questions? I think I was a bit concerned about the theatre statistics. Doesn't seem to be very efficient, is it?
We are bringing a paper back to FNP at the end of the month from the sort of the suite of theatres. So I think there's quite a mixed, again, probably a bit of a mixed picture, in terms of theatres run by the central team, theatres run locally, and there is for quite a lot of metrics around theatres, interestingly, through the enabling actions, the model hospital. So yeah, we bring that back to the LP to that deep dive.
Okay, workforce then, Shelley.
I'll just pull out 3 points from there to within the report. Something to celebrate, I think, is our turnover specifically, which is well below the target now, and a big mention to our registered nurses, because that's the lowest we've ever seen it. So registered nurses turnover is now 5.04 for June. In the report it will say 5.5 because that's May's figures, but it's come down again in June, so definitely something for us to celebrate. A challenge for us is we're still hovering below the statutory and mandatory training target, so just under 85%. But something that we're expecting any minute now is the outcome of the national review, which was commissioned by Welsh Government. So we're expecting some changes about how we report stat and mandatory training, and then specifically around some of the modules that we're asking our staff to undertake.
Can I pause you then? If people do not attend mandatory training, what is the employment relevance?
It depends on the role as well. So yeah, depending on whether you're a frontline clinician, but it's picked up through the PADR process.
That's a bit late though, isn't it? If somebody hasn't attended a mandatory training requirement and they're frontline.
Yeah, some of the modules will be constant to their scope of practice, so physically they can't practice.
Yeah, right.
But some modules will be picked up in terms of PADR, so the consequences might be that they might not progress in terms of pay progression, but accepted your point that PADRs are retrospectively rather than proactively, and so we're regularly reporting on a month-by-month basis, down to names and divisions and managers of where people haven't completed their training. But if there is a specific module that they need to undertake to practice, that will be highlighted by the continue to practice. And then, sorry, the final point I wanted to make is our time to hire, so which is completely under the 60-day target. So we're really shortlisting, interviewing and bringing people through the recruitment process much quicker now, which in turn we've seen a reduction of variable pay. I know we just chatted about the sickness absence methodology, and there's been conversations about the calculations for that. So we'll in my attachment to go through that.
Yes, it's been the same system for 25 years, I'm afraid.
Yeah, it's just concerns.
Yeah, I know.
I've got around how we calculate that figure. And what we're being shown here isn't quite right.
But I think it'd be important. We would have to move the whole of Wales, wouldn't we? But you know, it might be the moment to review this.
Yeah,
so that it's really relevant. Fine. Any questions to Shelley? Nope. The money.
Thanks, so
Oh, good. Okay. Oh, yes. It's not on my agenda. No,
Sorry, Anne. I'll try and be brief. So just to remind board members that this reporting is based on our old system of pillars, and we will have an amendment for Q2 in terms of our reporting against our new pillars, which consolidates a couple of pillars but also introduces a new pillar around clinical effectiveness. So that will be in our Q2 reporting. So just a few highlights. There are a number of changes coming in Civica over the next year, and there have been some issues with the system. We continue to benchmark well nationally at 85% for our Civica returns, 90% for our person-centred care survey. Some of the changes will be to include a maternity and neonate survey. So that will be coming in this year. And in addition, a friends and family test like we had in England is also coming as part of the person-centred care survey. So that's on a national basis, which will give us some benchmarking across the piece. We do make sure that we feed back to divisions. So our major theme is around waiting, and obviously we feed the themes back to the divisions. And other areas that come through have been infection control, dementia and bereavement, and you'll know we've done significant work in those areas. From a patient safety perspective, we continue to work on our NRI compliance. Our closure timescales are currently 60%, so that's an improved position. And we continue to work really hard around our decision making, so making sure that the right incidents are reaching the NRI threshold. And obviously you'll see within the report the detail of some of the themes. And what we're going to do is, for when we start to report moving forward, we'll start to pull out more on some of the low and no harm incidents as well. So you can see the thematic analysis coming through there. Our mortality rates remain pretty consistent and up to date of reporting. We are the best performing in Wales, and our mortality crude rate remains fairly stable and flat. From a concerns perspective, we're continuing to do further work on the data. So we have had a downtick in performance, but we've discovered 2 areas where we're not reporting consistently on an all Wales basis. So us and some other organisations were not reporting in line with the rules, which has adversely affected our performance. It won't take us right above the benchmark line, but it will improve our performance from what's reported here. We've continued to focus on early resolution, but we only have 2 days for that, and validation. So going back through the divisions around their performance, their aged complaints. I think we have 1 complaint now, which is over 12 months, which is a significantly improved position. From a health and safety perspective, our RIDDLE compliance has improved, and it's good to see an uptick in our manual handling training as well, which is also improved, which will help our, I'm sure, our mandatory training compliance if we're getting our mandatory training up to date. 2 final areas. So from an infection prevention control perspective, C. difficile remains a challenge. As you know, we are doing better in this quarter. However, we are in a summer month where these infections will be more at bay. And I'm pleased to say on all but 1 infection, we are below the All Wales average. So Pseudomonas is the only area where we are above, and Pseudomonas is such small numbers that can actually throw out your reporting. So we continue to focus on our basics of infection prevention and control, making the right decisions with Tracy and her team on instigation of additional measures. And there is a national collaborative that's been launched, led by Rhiannon Jones, which will focus on C. difficile. So trying to share good practice where we have that, but also trying to understand about, you know, where are we innovating, where are we looking differently. And as you know, we have an antimicrobial detailed action plan in place around the impact of antibiotics on some of our infection rates. So lots of work, further work to do, but obviously IPAC will remain a focus for us going forward. And just to say on safeguarding, our level 1, level 2 training compliance is there or thereabouts 80 to 85%. Our benchmark is 85%, but we're there or thereabouts. We need to do further work on safeguarding level 3. So we've seen a huge oversubscription of courses, but we've had a lot of people drop off. So we need to make sure that our courses are full. And as you know, it will take us probably 2 years to recover the position. So we can't afford to have a drop off. And our child due to reports are fairly stable, but our adults continue to rise. We believe that's because there's increased awareness of capacity, of deprivation of liberty safeguards, and of the impact of domestic abuse and other abuse on adults, particularly older adults. It puts pressure on the team, but it's good to see that people are coming forward and reporting. The whistle stopped tall for me, Anne. So
thank you very much, Jenny.
I can breathe.
Any comments to Jenny or questions, Akmal?
Yeah, thank you, Jenny. Are all of these trainings done online? Is my first question.
So it's mixed. There's part 2. I think there's 3 elements actually to manual handling. One is face to face, which is obviously more tricky, and level 3 safeguarding is face to face because it's mandated. There's a national mandate around safeguarding training about a multi-agency component and a face-to-face component. Right. So it can't all be done online for some of, particularly the clinical areas.
Because I mean, that impacts the compliance rate as well, you know, as the chair had mentioned earlier on, to be able to understand that. And my second very brief question would be your compliance rate on fire safety. How is that reflecting, or you didn't hear much about fire safety?
So we have a very detailed health and safety action plan. Peter is our lead for health and safety and fire. And we've done a lot of work focusing on access to training and support for training. And I don't know, do you want to say any more about our fire training?
I don't know any more detail on the fire training, but there's been a lot of investment as well around the infrastructure for that to enable that to move forward. Yeah.
So it is a focus, and we do work really, really closely with the fire service as well.
Yes, we had a detailed discussion on fire safety about 18 months ago. because it was an issue of concern, and a lot of action has been taken subsequently. That's still on the
I'm sure we can share with you, Admiral,
Yeah,
the previous paper that the board had that went into some of the detail around the improvements.
Thank you. Yes.
Thank you, Jenny. Any further questions? No? No, I've left the money.
Thanks, Anne. So the report that you've got in your pack today is to the end of May, so 2 months year to date end of May. The position for revenue is a year to date forecast deficit for, year to date position of £4.6 million deficit with a forecast break even. In terms of the capital position, there's £3.7 million spend of the £32 million which we've had allocations for as a percentage spend on the year. That's a positive position, and we're expecting to achieve balance on that. And we do usually get some year-end additional funding, so we'll utilise that as and when that becomes available. Our public sector payment policy, which is a measure of how fast we pay our invoices to the private sector, is 97% against the 95% target. So again, we're achieving that. Of keynote is obviously we're running in the early part of the year, so it's 2 months position, but the revenue forecast is amber rather than green as a break even. We do have to, on the basis of the position reported, some of the work that we do through our financial reporting arrangements has identified £7 million pressures above our planned position that need to be mitigated to deliver that financial break even. So there's a risk there, and we will need to, in the balance of the year now, identify additional mitigations. In terms of the report, in case somebody has not just picked this up, is that we have not in the schedules of this month 2 report reflected the phase 2 budget delegations that we've just agreed, because we've just agreed them. So some of the narrative points and the reasons for variance will be refreshed when we get to month 3, when you can see where the variances emerging with the delegations coming through. So the narrative really relates to changes in our spend forecasts as opposed to variances driving those changes, if that makes sense. So in terms of the key points for the month, our pay and non-pay costs are running above plan. That's which I suppose that's obvious, driving the deficits. Our plan does show a reduction in our spend profiles towards the latter part of the year as we identify and deliver further opportunities as per IMTP plan. So again, we'd expect the run rates of costs for pay and non-pay to reduce along to that towards the end of the year. In terms of what's driving our changes then in terms of the overall forecasts, there's several things that have emerged in the first 2 months of the year that we are able to clearly estimate the impact on our forecast because they've happened, some are yet to happen. So if I go through the main things, so we ran Wind Towards beyond the original plan for a couple of months, so that's something that this directly affected our forecast because it's happened. Our drugs costs for prescribing in particular, when we set our plan and when we cast our financial accounts, prescribing costs, because that's the biggest part of our estimates on drugs, are based on data that's 2 months old. So that's because every month, so for the May reporting, we only have data to match. It's a national issue. The importance of that is now we're reporting May, we have March's data, and our forecast for the full year for last year was £1 million underestimated. We've been looking into it to see if there's any implications of a GP system change and whether there was some contingency prescribing in March to allow for that system change and keep people safe with their drugs. We're confident, unfortunately, that doesn't cover the full £1 million, but that's something we're looking at. But there's £1 million move there. We also, again, in terms of the timing of our plans, so we cast our IMTP plan and financial plan ready for the board early in March. During March, we had some issues emerge that we had to manage. Part of that is the timing around recognising benefits from some of our disputes around mental health, and we reported those and took the benefit of those in the old year, whereas the plan were expecting the delay to recognise those. So that as a consequence has had an impact on this year's spend profile. We've seen additional spending for discharge to assess cases, which is the more complicated cases that go into a holding position for CHC, particularly around where they're one-to-one and more complex before they then convert to our standard CHC packages. And part of that is to manage, as I mentioned, the one-to-one care. So the recurrent packages that are in place are effectively dealing with patients with lower care requirements, and then are at a lower cost to us in terms of commissioning those packages. And then we've, in terms of our 104 weeks, we've overperformed against some of the funding we've had for that. There's obviously a benefit to that, to our wait-ins performance, so that's reflected in the report as well. And some other considerations that are currently being vetted against the reserve usage from the IMTP, which we talked about earlier. So in the round overall, that's where the 7 million comes from. In terms of savings position, so the IMTP identified savings mix, I'll describe them in 3 ways. Green savings identified at 15, amber savings that we had a line of sight on through our route map work of 10 million, and then reds, which were opportunities not yet identified, of 14 million. That's what the IMTP plan stated. In terms of where we are against those targets, we've been able to shift the amber category, £4 million into our green category. So our current position is £19 million of green, or what we consider to be achievable savings, 6 million residual as amber, where we've got a line of sight around some of our value and sustainability themes, but we do need to finalise and deliver those. But the £14 million reds, which were reported as not yet identified and deliverable, still hold at the end of May. Obviously, in addition to that, we've got our additional cost pressures I've just gone through, 7 million that need to be identified, mitigated and delivered to hold our financial forecast as balanced. So I'll come back to the point that in the summary dashboard, that forecast is amber. On a more positive point, our cash holding position was 2.4 million at the end of the month, which is well within the £6 million guideline established by Welsh Government. I'm conscious it's a very early monthly report for the year end, so I was using the forecast. So I'll leave it there and look at your questions, and if that's okay.
Thank you, Rob. Are there any questions to Rob on the money? Akmal?
I think you explained it very eloquently in terms of what is happening. Just wanted your sort of feeling as to it's early on in the next year, but going forward, how do you feel? Do you think we can still make to the plan, or do you think that there's going to be some areas that the board needs to be concerned about?
There's definitely areas the board needs to be concerned about, but in terms of where we are now, there's in terms of month 2, say so it's 2 months in, we've got another 10 months to go. So there's significant, very real risks to being able to deliver our forecast. We were very clear in those in terms of when we discussed at the board and the risk and the ambition that we put forward. So Welsh Government are aware of this. We're very clear in our monitoring in terms of the levels of risk. But we're probably going to need to step up the rigour of delivery setting budgets and delegated phase 2 budgets out. Hopefully we'll get a bit more ownership on that. But again, this is about cost reduction. So whilst budgets sort of give a scale of stretch they're required to meet, we've got to reduce our costs. So there might be some in the future, some very challenging decisions that the board will need to make. So coming to your point earlier, Paul, what did you do? I think the consideration is why we need to make difficult decisions, just to be aware of why they're being brought.
Thank you. Any further comments, questions? Neil?
Just building on that point, we've been on this cost-cutting exercise now for quite a considerable length of time, and I'm just curious to know, I mean, whether we have, at the beginning of a process like that, you have the kind of low-hanging fruits, don't you? And then as you get into the process, savings become harder and harder to find. But at the same time, if you are constantly engaged in a search for more and more innovative ways to make cost savings, perhaps even involving investment in things which could quickly deliver operational cost savings. And I just wonder whether you could give us any sense of which of those scenarios you feel closer to at the moment.
So I think if you take probably answer this, if you take a step back in terms of where we find ourselves currently in an operational scenario. So we've got, over the last couple of years, we've undoubtedly gone at the low hanging fruit and some of the harder stuff as well. We're in a current context of the organisation being put under extreme pressure to deliver 104-week and other waiting times. There's an opportunity cost there around how our staff, the staff that deliver the savings, isn't it, can give their focus to creating savings. There is something about, through the furor of everything we've been asked to do, through some very unusual things, so our internal and external sourcing of external services to deliver waiting times is a massive burden on staff. It's a burden on our back office, particularly procurement, to do things properly. But there is something about us holding to our financial control governance. We can't let that slip. We can't take shortcuts just because we're under pressure to hit targets. That's one big thing we do need to focus on. The other element, I think, is in terms of the ability to secure additional funding for what we're being asked to do. We touched on previously, didn't we, around a national contract for insourcing, and we have written to Welsh Government to be clear that that contract pays for the service for the external provider, but we have to put a significant level of infrastructure around that. And the responses to, something came through this morning, the responses to our cost estimates have not been met anywhere near. I need to check what they've come back to us with. There is something of the order of about 20% of our estimate. So one of the things we had is, so there's a cost pressure we've incurred in Q1 to go beyond the funding we were given for Q1 for RTT targets. There's a spectre of additional funding for that, recognising we've hit our target and gone beyond it. But right now, that's a cost pressure for us. There's a bigger risk around what is being established nationally, if I'm honest with you. So the reason I've raised that is it's kind of an invisible pressure that's being placed on us. And then you can imagine, as everybody can, the target performance pressure that we're expected to deliver against. For good reasons, patients are working too long and, we need to do things. But why I've sort of talked about that a little bit more is the resilience and the ability of staff to really focus on savings delivery, because we're into the more complicated pieces, choices and decisions around, you know, the thrift mentality that I think we've managed to ingrain a bit more the last couple of years. Perhaps slips when it's people are under pressure, time pressure, decision making. Plus also when we're looking at larger propositions for savings, you need people to wrap around and do, you know, like a mini business case as such. So we've got, particularly for QA requirement, we've run the QA process now. We've managed to have a couple of things that we're still working on to absolutely get that impact assessment and whether things are appropriate to progress with from a patient safety perspective. So to answer your question in concise terms, given all that I've said, there's a lot of competing priorities with money and savings being in that mix. And I think it's fair to say others may disagree that it's not the top of that list for a lot of people because of the pressures from elsewhere and other delivery requirements.
Thank you. Any further questions to Rob?
Okay.
Can we move then to 6.5 strategic risk report?
Thanks, Chair. There's no changes recommended in the risk report following the risk judgment committees. Yeah, there's a particular focus on the risks, the 6 kind of key sub-risks that sit outside our appetite. The highest one there, which talks about our financial sustainability, which is very relevant to the discussion we just had. But, you know, again, I think if you look at our agenda today, we've pretty much I've got to focus on a number of those. I think, you know, we can't take our eye off any of those. There is significant pressure. I think health and safety, as we'll pick up with Akmal Rays, continues to be an area we've got a lot of focus on as we try to strengthen our governance. To make sure we keep a focus on that one. Obviously, business continuity, there's a number of exercises going on nationally as well that kind of keep our focus on major incidents and otherwise business continuity planning. And obviously, in terms of RAP, we just have the level hold the pace in terms of our engagement and our plans. So I feel that we've got a good focus on most of these areas and seeing improvements in a number of these risk areas. But happy to take any questions.
Thank you, Nicola. Are there any questions? No, I think it's quite clearly explained and we have discussed them. Okay. On the consent agenda, you're happy to adopt the consent agenda?
Yes.
Without further discussion, okay? So the date of the next meeting, 24th of September. Here. Now you have a choice, and we have an